interfering. I'm trying to stop share and they are not allowing me. It's
Okay,
crazy. Now I'm on. Yes.
Hello, sir.
Anytime they mute me, anytime they unmute me. Jignesh is creating problems for us. Okay, now I don't. Do I have a full picture? No.
I'll start.
Yes, Sarita, you can start.
Yes, ma'am. Yes.
Good evening to everyone, and welcome to the day one of the 3-day prestigious ICOG certification course on endometriosis. And a warm welcome to our series convener, Dr. Sheila Mane, who is the Vice Chairperson ICOG, President ISOPAP and Menopause Society Bangalore, and a very humble and a loving personality. Madam, we request you for your welcome words. Sheila, ma'am.
Good afternoon, everybody. And again, it's my proud privilege to be there on the. Yeah, can you hear me?
Yes, ma'am.
Can you hear me?
Yes,
Yeah.
yes, ma'am.
It's my yeah, proud privilege to be there here, welcoming everybody. And I know that the endometriosis certification course is going on very well. Thanks to Dr. Asha for taking up this initiative. And as it is the need of the hour, and we see that the incidence of endometriosis as well as adenomyosis has gone up. And I think there is a need for all of us to know that what are the newer trends and what are the newer things for the management. So I welcome everybody and thank you, Dr. Parul Kotadwala, our chairperson, for encouraging all of us for taking up these certification courses. And I think this is going on very well. So congratulations for that. And today's our guests again, Dr. Prakash Trivedi and Dr. Uday Thanawala. All of us, we know that we have Dr. Prakash Trivedi with us. I think all of us, we know that we can call him as a legend in laparoscopic surgery.
Ma'am, we have
as
Dr.
well as
Sheila, they are tomorrow. They are
Prakash
not
Trivedi
today.
is tomorrow.
We have Dr.
Sorry.
Today,
Jaideep
Jaideep
Cancer
Cancer
and
Okay,
Madhuri,
okay.
madam.
Okay, so Dr. Madhuri, we heard just now. I think she has just returned and still she has made it a point to join this program. And today's topics are again very interesting, like it will be fertility preservation as well as dealing with adenomyosis. And I'm sure that all the faculties are, will be doing a excellent job, and it will be useful for all our people, those who are participating in this certification course.
Right.
So welcome once again, and thank you for the invitation. Yeah.
Thank you so much, madam. And now we invite Dr. Parag Pinnewale, who is the chairperson-elect ICOG, past president Pune Obstetric Gynec Society, a great teacher and very
Thank you, Ritu. Thank you. I think let's not waste time. Let's invite the chairperson, Dr. Parul Kotadwala, for his address. Of course, we first have the traditional lighting of lamp. Yes, maybe request Dr. Parul Kotadwala, the ICOG chairperson, for his address, please.
Thank you, Parag. Well, this course is going on so well that without spending a lot of time in formalities, we should start off. Endometriosis is the in thing. And along with PCOS, these two are the most discussed things. And unfortunately, we do not have answer to all of it. Maybe in days to come, with Foxy Endometriosis Committee bringing up something new, we will have something. Well, I compliment Dr. Asha, Dr. Ritu, and Subhash is there, yes. All three of them for putting up a very good show. And with Foxy Chairman of Endometriosis, Dr. Anu, I'm sure this will be a great program. compliment to you all, and please continue with the program.
Thank you, Dr. Parul. We have Dr. Madhuri Patel, the Secretary General of FOXI with us. May I request Dr. Madhuri to say a few words, please?
Thank you, Parag, for your kind words. And I must congratulate Dr. Parul, Dr. Parag, and Dr. Sheila and Sarita, and of course our endometriosis chair, Dr. Anu, and Dr. Asha, who is our immediate past chair, for bringing out such a great online, certificate course on endometriosis. So with this, I would like to address that our chief guest, Dr. Jaideep Tang, President FOXI, very supportive. Then Dr. Parul Kotrawala, Chairperson of ICOG, Dr. Parag Binewala, ICOG Chair-elect, Dr. Sarita Balerao, Secretary of ICOG, Dr. Sheila Mane, Vice President of Vice Chair of the ICOG. Again, series conveners, Dr. Sheila, Dr. Parag, and Dr. Charmila. Convener, Dr. Asha Rao, Dr. Anu, and Dr. Subhash Malya. Coordinator, Dr. Ritu, Dr. Kiran Pandey, Dr. Bhakti Rajshekar. And of course, today's chairperson, Dr. Mandakini Meg, Tushar Kar, Dr. Archana Bashir, Facey Louis, then speaker, Dr. Kalpana, then Kuldeep Jain, Dr. Sonal Panchal, Dr. Parishik Tang, and again Kundan Ingle, Gaurav, Lakshmi, Shrikhande, Pratik Tambe, and Sonal Kotrawala, Ramni Devi, Dr. Damodar Rao, Dr. Sylvia, she's from Italy, who is going to address, she's going to give her a talk, and all my dear friends. Very good evening to all of you. I am so happy that, as Dr. Parul has said, that endometriosis is becoming like a PCOD, disease. So I am happy for one reason, that we are learning, we are going into detail about it. And as all of us are aware that the girls are getting educated, so the marriage, the age of marriage, the age of pregnancy is postponing. And therefore we see many endometriosis in the advanced stages. And whenever the young girl comes with dysmenorrhea, we think it is only because of the spasmodic dysmenorrhea, which is physiological. But I feel we should investigate her thoroughly with the dysmenorrhea as well as the chronic pain. I can give you two examples that they present with the chronic pain and the infertility and menstrual disorders. But chronic pain, I have seen that they are most of the time with advanced endometriosis. Infertility, it's really, they come only with the infertility, and we have to be very, very drastically treating the infertility, and we must try to tell her to conceive with our treatment. And what I have seen, that once the pregnancy, during pregnancy, whatever the endometriosis was there before pregnancy, after pregnancy it just disappears because of the high doses of progesterone. But in an advanced stage, even the IVF doesn't work. So we have to act very, very, very drastically to give the justice to them. And I remember one of my patients many years back, 10 years back, she came with severe menstrual disorders, heavy bleeding, with severe chronic pain. She was below 40, she has completed her reproductive function, and she just wanted, hysterectomy with bilateral salpingo-oophorectomy. We refused because she was less than 40. We told her she medical treatment, but she just refused. Conservative treatment, she just refused. And ultimately what happened, we got succumbed to her request, and we went for abdominal hysterectomy with bilateral salpingo-oophorectomy. And what happened? That she kept on oozing from the pelvic veins, which we could not control. We tried our best, and at the most, we kept a pack. Pack was removed after 48 hours. Still, bag was persistently, the drainage was coming. Pack was removed. Again, she was packed. It happened 3 times, and ultimately she could get cured. So sometimes the venous ooze is also very bad in endometriosis. So keeping in all these factors in mind, we have advancement in the treatment. We are going to learn from all our experts, and I wishing all of you best luck for such a lovely, course, which will really, teach us something to implement in our practice to benefit our women. Thank you once again for giving me this opportunity.
Thank you, Madhuri, for those kind words. And I must appreciate efforts put in by the conveners, Dr. Asha Rao, Dr. Anu Chawla, and Dr. Subhash Mallya, and of course the coordinators, Dr. Ritu Khanna, Dr. Kiran Pandey, and Dr. Bharati Rajsekhar. I think, Asha, let's straight away begin with with your preamble and then pre-test.
Yeah. Just 1 second of share screen. Yeah. Dear friends, can you hear me, Parag? Can you hear
Yes,
me,
ma'am.
Parag?
Yes, ma'am.
Yes.
Yes, ma'am.
Dear friends, welcome all of you to this prestigious Foxy ICOG Endometriosis online certificate course. And I thank our stalwarts, Dr. Jaideep Tank, President Foxy, Dr. Parag Benewale, our chairperson ICOG, secretaries Dr. Madhuri Patel, Sarita Bhalerao, Parag, Sheila, and the team for having given us a lot of encouragement and support to conduct this course. I really thank them for the opportunity. And as all of us know, endometriosis continues to be enigmatic, elusive, and in spite of a research of 200 years, yet we have difficulties or dilemmas in diagnosis and disputes in management. And it causes severe dysmenorrhea, chronic pelvic pain, fertility problems, and brings down the quality of woman's life. And there are more than 190 million women suffering from endometriosis world over. And of these, we have a big chunk of proportion, that is about 30 million women in India alone. And there seems to be a tremendous delay in diagnosis. Almost 5 to 7 years before these young girls or young women come to you. And then sometimes there is a surgical diagnosis, multiple laparoscopies, sometimes laparotomy, leading to exhaustion of the ovaries. But today we are glad that a lot of changes have happened. In a practice of 40 years, I have seen a lot of changes happening in the field of endometriosis, right from diagnosis to management. Today, we do not have surgical diagnosis anymore. We can diagnose it very nicely with the help of imaging, maybe most often ultrasound, sometimes MRI if needed. And there has been a rethinking on endometriosis. It can be suspected without surgical exploration. Medical treatment can be prescribed without histological confirmation. Diagnosis of endometriosis is no longer considered as synonym of immediate surgery. This is a very big change. And you can see the change in stand of HRA. 2013, they recommended that clinicians perform a laparoscopy to diagnose endometriosis. But today in 2022, HRA recommends laparoscopy only when if there's a negative imaging result or where empirical treatment was unsuccessful or inappropriate. So laparoscopy is done more often as therapeutic procedure and not diagnostic procedure alone. And for very many years, we managed endometriosis surgically, multiple surgeries. It recurs, again, we do a surgery. So today, we know that we have to avoid surgery as much as possible, do it only if necessary, and treat them more often with medication or ART to help their fertility. So it is very important to avoid surgery for diagnosis, avoid multiple surgeries, ART to improve the chance of pregnancy, avoid pre-ART surgery if you can. And again, the trend is for frozen embryo transfers rather than fresh transfers. Long-term management with medical therapy, once again trying to avoid repetitive radical surgeries. And this is a beautiful slide by Chaperon et al. You can see. Initially, we did endometriosis when it's suspected. We did immediate first surgery, followed by half-hearted post-operative medical treatment, which led to recurrence. Once again, repetitive surgeries, and at the end of it, ART, ovarian exhaustion. So maybe sometimes egg donation or even surrogacy. But today, what we should be doing is non-surgical diagnosis of endometriosis. And these young women do long-term medical treatment, avoid the recurrence, suppress the recurrence. And when they want to get pregnant, help them either by IUI, ART, or if necessary, do a complete conservative surgery only at that time. And once again, after childbirth, long-term medical management, again avoiding radical surgeries. And this year we brought out a Foxy Focus under the leadership of Dr. Rishikesh Pai on endometriosis and adenomyosis. And also we have done a GCPR. So just like Eshre, who has done a beautiful guidelines, we have tried to make Indian guidelines, and I'm sure it will be available to you shortly. So all in all, we should promote medical management because endometriosis is a chronic inflammatory disease which requires a lifelong management plan. And the goal is to maximize the use of medical management and avoiding repeated procedures. So I think I'm not going to take too much time because we have lovely speakers. We have 8 speakers every day for the next 3 days. And we are going to discuss very many topics of endometriosis. So I will not stop between you and the speakers. So thank you, Dr. Parul and Sarita and the team for having given us this wonderful opportunity. And let us go to the academic program and let us go to the pre-test now.
Gauri, please post the link in chat box and put the timer on.
Where are the questions?
Sir, yeah, link is posted in chat box, sir.
So then somebody has to look at it from another mail ID and okay.
Just click on that link, sir. It will be open. Page will open.
So
And then submit. Yeah.
A new, so everybody go on the chat box, click on the link, and a new window will open, and there you can answer.
Thank you. So that was required explanation. Yeah.
I think we have to be fast in filling up all the name and mail ID and all that.
Don't forget to put your email address, your phone number, and name at the top.
So all that is part of 10 minutes?
Yes.
Yeah, exactly 10 minutes, including all. And we have 30 questions, so we have to be rapid.
Timer is on, ma'am.
Because once we go to this page, we can't see the timer.
I think one of the admin, you can tell after every 2 minutes how much time is left. And at the end, every 30 seconds.
Yes.
We have the timer on this page, Nilima? I do not know.
Yes, timer is on that technical person window.
But the delegates are not able to see it.
No, they will appear on their screen.
If anyone is struggling to follow, you can write on the chat box and we'll repeat something that you need to know. Shivani, just click on the link again. Make sure your network is good. You should be able to open. And Madhavi, you have to put the details on the form, on the link, on the new window, not on the chat box, please. Otherwise, your submission won't be noted.
Yeah, Manda. Yeah. Sunali, Dr. Mandakini needs to be unmuted. She's requesting.
Yes, Gauri, please make co-host to ma'am, please.
Nilima. I think Gauri.
Yes, ma'am.
Madam requested to be unmuted.
Done, ma'am.
Still showing that red sign. Oh, okay.
Hi, Anu. Good evening.
Hello,
everyone. Hi, Anu. Can you see
hello,
me?
madam.
Yeah. Can you see me? Am I audible?
Yes, madam, you're audible.
Yeah,
We can.
yeah. So I can see the Asha. I can see the course so much flourishing, and we were the one to start this course.
You were
in
the one you were the
chairmanship.
one who gave me the first chance to do
Yeah.
the course. Thank you so much.
We conceived this course. We, made the full course, and then after 3 days we took exam, and I think that time also around 300 to 400 certificate. We distributed after passing 50%, and it
Yeah.
was real nostalgic. I'm today feeling. So Anu,
Yeah, really.
all the best, all the best, and Ramani Devi, myself, and Asha, we were done. That time we started. So now I can see it so much flourishing and so much nice. Congratulations to Dr. Parul Kotadawala, Parag, Vinniwale, Sheila, Sarita, everyone taking this course ahead and making it much more comprehensive and very good. So it is improving a lot since my time. And thank you for inviting me for this program of certificates.
During COVID years, you did a wonderful job, Manda. It was
Yeah.
a great year.
We conceived all these certificate courses now because initially there was somebody suggested, why don't you have exam? So I started taking exam, pre, post, and then 50% attendance, all 3 days attendance. And it was wonderful now. And all the
I would request Gauri and Jignesh's team to do two things. Firstly, can you mention the time left for the candidates? And also the second thing, can you also give a backup support phone number because Shivani is still not able to open the link. So maybe she can talk to you directly on some phone number. If you can give a little helping number, phone number on the
put a
chat.
helpline in the chat box.
So Shivani will give you a helpline number. You can call on that number and they'll help you. Already Natasha has already submitted. So great. Well done. That was fast. So there's a number here on the chat box. You can call on that number if anybody needs to help to ask any questions. And again, Sashmita Behera, you're also not able to open. So call on this number if you need help. If you make sure your internet connection is good and if you click on the link, it will open a new window where you will see the form which you have to start filling by putting your details first and then answering your questions. Great. So now people have started submitting. Gauri, you can just announce the time left, please, just for everybody's orientation. Sorry, Dr. Madam Meg, I had to just mention this.
Yeah, they have 1 minute, 42 seconds.
Hello. आप मुझे व्हाट्सएप पे
Don't worry, Meenakshi. Yes, all thanks to you, Dr. Meg. You have been a mentor to all of us. And Dr. Parul has given me this opportunity to be a part of this program with Dr. Asha Rao. Dr. Asha Rao has done a great job putting things together already. So,
And I also acknowledge the presence of Ritu. Ritu.
Madam, yes, madam.
Good evening. Lot of
I
program
think,
in the Varanasi.
Yes, and
that
we
time
got
my secretary was Parag.
yes,
and,
madam. We had a
life-
wonderful time.
Yeah.
The whole year was,
Actually, it
very
was
vibrant.
trial. It was a time of trial and error.
Yes, ma'am.
There were not many errors, but trial was quite good.
Yeah. Somebody
And
says
we
the chat
did,
box, meeting ID and passcode not working.
Yeah.
Gitanj.
I think a lot of submissions now being done. Most.
So, Anu, how are you? Which country you are in now?
this is my constant first question that when I meet everybody. So I just came back from Ludhiana, actually, just 3 days back. So right now I'm in London, madam.
Okay.
Time up, is it?
Madam, yeah, time is finished. Ritu ma'am, go ahead.
So yeah, we can start starting with the scientific session. I would like to invite the chairpersons for the first session. The chairperson for the first session is Dr. Mandakini Meg, who has been the chairperson ICOG Foxy 2021, International Vice President MWIA Central Asia, Vice President AMWI Central Council, and with lots and lots of awards to her credit. Welcome to you, Dr. Mandakini Meg, ma'am. I also invite Professor Tusharkar, who is the professor in Unit Head Department of OBGYN, SCB Medical College, Cuttack. He's the president of Association of Obstetrics and Gynecologists of Orissa, vice president of Foxy 2010, and he's published more than 50 articles in the national international journals. Welcome to you, Professor Tusharkar. I also welcome Dr. Archana Baser, who has been the Vice President of Foxy 2020, Organizing Secretary of AICOG 2021 in Indore, and Fellow Representative AICC RCOG West Zone, Imaging Science Committee Chair CEFOG also, and welcome to you, Dr. Archana, Madam. We also invite Dr. Fessy Lewis, who is a Senior Consultant and Associate Professor in Charge MCH course, Department of Reproductive Medicine and Surgery, Amrita Institute of Medical Sciences, Kochi in Kerala, Foxy Vice President-elect 2021, and ISA National Executive Member. He has also been the Vice Chairperson, Kerala Chapter, IIG, and I think a very meticulous personality. So welcome to all our chairpersons, and I invite Dr. Mandakini Meg, ma'am, to invite Dr. Kalpana for her presentation.
So, good evening, everyone. At the outset, I'd like to thank, and it's really a nostalgic to visit ICOG office and the certificate course. And I can see all my dear friends here. Dear Asha, Anu, Kalpana, we have been sleeping together at all the election places. This is a national platform, but I'm telling you, she has been very good with, traveling all over. So Kalpana, thank you very much for all the support. And Parul Kotadawala, chairperson at the moment, and our Parag Bendiwala, thank you very much. I was just discussing that we have started with the COVID. Everybody knows, I should not repeat, but everybody started these courses when we were, struggling with how to cope up with the ICOG work. And that time, Ramani Devi and Asha Rao came, and we had so many courses. I think I should not enumerate, but I'm extremely happy as a past chairperson that you people are doing, extraordinary work, and you are taking that more further. You are purifying the course, you are making updating, and I think the students will be very much benefited. With these words, congratulations all of you for this course, and it will be a great success, Asha and Anu.
Thank you.
Kalpana, Kalpana is a younger sister. She is a chairperson infertility committee, co-director of fellowship in endogynecology, co-chairperson of infertility TNFO, vice president in Madurai. And she has been perfect host, Kalpana. We have coming to Madurai so often. And then organizing secretary for Silver Jubilee Conference. I have attended all her conferences, and also the adjacent places also she made me visit, and that was wonderful. And she has received many awards: Best Doctor Award, MGR Medical University, Golden Excellent Award.
Thank you,
So
Dr.
many, so many awards. So I think you are going to get a academic feast, and she is going to talk on Kalpana. I don't know the subject, so please forgive me. But then you can.
Kalpana can share her slides, please.
Yeah, please. So, hi, Bessie.
We'll request all the speakers to be just for 12 minutes and chairpersons to be a little short. We are already delayed by, I think, around 12, 13 minutes.
Yeah, we also request the chairpersons to introduce the speakers in 2 sentences. That will be very nice. Yeah.
Thank you, Mandagini ma'am, for your wonderful words. And it was really a wonderful time we had together last year. And it's my pleasure to be a part of this wonderful ICOG online certificate course in endometriosis under the leadership of FOGSI President Jaideep Tank sir, Chairperson ICOG Dr. Parul Kotwada sir, Secretary General Madhuri Patel ma'am, and Secretary ICOG Dr. Sarita, and series conveners Sheila Mane ma'am, Parag sir, and Dr. Charmila. And my sincere thanks to Dr. Asha Rao ma'am, who had taken so much efforts to organize this program in addition to her, Dr. Anu, Dr. Subhash, and all coordinators. I also thank Dr. Casey Louis sir, Tusharkar sir, Archana Bazair ma'am, in addition to Mandagini ma'am for chairing this wonderful session. Going to the topic, etiopathogenesis, even as Asharao madam told, endometriosis even now remains an enigma because the symptoms do not correlate with the severity of the disease. Various hypotheses have been put forward to explain the disease nature of endometriosis. But coming to the incidence, it is almost 5% in common people, and in infertile couple, it is almost 10 times higher, 50%. So various theories have been put forward, starting from Samson theory, coelomic metaplasia, vascular dissemination, direct transplantation, and altered immunity, stem cell theory, and genetic origins. So first and foremost was Samson theory, which was taught to us during our MBBS level also, which says that retrograde menstruation is the starting point, because it was really positive because endometriosis was common in dependent portions of the pelvis, and it was quite common in Mullerian duct obstructive disorders. And also, if a patient has got early menarche, late menopause, and heavy menstrual bleeding, in that occasion, the incidence is slightly increased. The problem with this theory is even in patients with Mayer-Rokitansky, few patients had endometriosis and few patients had endometriosis even after sterilization. So the value of this theory is debatable. Then came coelomic metaplasia, Mayer's theory, which was also reasonably acceptable. In 1890, von Recklinghausen embryonic rest theory was introduced. Remnants of Mullerian duct can give rise to endometriosis was this concept, and induction theory in 1995 by Levander, who tells that even mesenchymal cells can be differentiated into endometriosis by the substance released by degenerating endometrium. But many times we see endometriosis in the pleural cavity and also pericardial cavity, even in CNS. So venous and lymphatic spread could be a reason for this distant endometriosis, and direct implantation was also possible that we can see in scar endometriosis. So we should be very careful in peritoneal surgery wherever we deal with endometrium. So whatever may be the mechanism by which endometrial cells are deposited in the ectopic sites, immunological theory is also important, because many a times, almost 95 to 99% of patients get retrograde menstruation. Out of that, only 5% of patients do get endometriosis. What could be the reason for this? Because this foreign body is recognized as ectopic endometrial cells are recognized as foreign body, and this immunological mechanism, natural killer cells and humoral immunity will destroy this ectopic endometrium. But when this is altered, maybe cellular or humoral immunity, if it is altered, naturally this ectopic endometrium will grow in the adjacent sites. So this is a reasonable one, and macrophages and NK cells, which are actually acting as scavenger cell, are deficit in this place, and they actually secrete some growth factors. Ultimately, this ectopic endometrium grows and proliferates. Various cytokines are involved in this, and inflammatory process is a part of endometriosis pathogenesis. Interleukin 1 will stimulate other factors like interleukin 6 and 8, and interleukin 8 is involved in adhesions and invasion also, where matrix metalloproteinase is increased, and TNF alpha is responsible for adherence. VGF, as we all know, that it increases the vascularity. Genetic theory is a reasonably acceptable theory, because even first degree relatives have they have a risk of almost 6-fold increased risk of endometriosis, and it is quite common in homozygotic twins also. Possibly various genes are involved in this, and estrogen receptor gene polymorphism is a reasonable theory, and changes in 7th gene and chromosome 10, 11, 16, and 17 had been documented by various authors. These are the list of genes involved in endometriosis, initiation and progression. Epigenetics is also really important in the etiopathogenesis of endometriosis. Altered methylation and acetylation of microRNA is an important mechanism by which ectopic endometrial cells will survive. HOXA10 and HOXA11 genes are really involved in it. So basically, hypermethylation will cause reduction in HOXA10, and progesterone receptor B is downregulated. E-cadherin is also altered in these patients because of epigenetic alteration. DNA hypomethylation will ultimately result in increased aromatase, which would increase estradiol level in the local environment. And COX2 gene is also increased, which is a marker of inflammation. So ultimately, prostaglandin levels are high, which would ultimately increase estradiol level in the microenvironment. So stem cell theory had been also documented, originating from bone marrow will change into ectopic endometrium, and then that would proliferate and grow as endometriosis. So the recent theory is infection and epigenetic pathway. Various organisms had been documented. This is a paper published in 2018 by Campos et al., who concluded that the incidence of mycoplasma, ureaplasma, Shigella, E. coli were relatively high compared to normal patients, almost 54% compared to 33% in normal patients. And another study published in 2019 concluded that HPV infection is higher in endometriotic patients compared to normal patients. Shigella, E. coli, enterococci had also been documented in higher incidence in endometriosis patients. So this infection may interfere with the contracting capacity of the myometrium. So ultimately increased retrograde menstruation, and added on to it because of infection, oxidative stress will ultimately result in proliferation of the endometrium. And environmental toxin also plays a role in this. Various ion channels like calcium channels are also involved in this pathogenesis. So whatever may be the initiating trigger, ultimate pathogenesis is almost similar. Various, even though it is considered as a benign disease, almost the process is similar to oncogenic pathway, where we have adhesion, invasion, and metastasis. So similar to that, we have various cytokines, matrix metalloproteinase, VEGF, involved in this pathogenesis, the local increase in growth factors and altered hormonal milieu, estrogen and prostaglandin, which adds on inflammation in this process. So when the ectopic endometrium is deposited in the ectopic site, cytokines will increase the adhesion of the ectopic endometrium to the matrix. And matrix metalloproteinase is really needed for invasion, which is really increased in endometriosis patient. VEGF will cause angiogenesis, and various growth factors are increased in the environmental milieu, and local estradiol level is comparatively higher in endometriosis patient, and ultimately prostaglandin is also increased. So ultimately, because of increased aromatase, estrogen is higher in endometriotic microenvironment, which will result in proliferation of the ectopic endometrium. And tissue injury and repair mechanism is also involved in endometriosis pathogenesis, which ultimately results in increased aromatase, which finally causes increased estradiol in the local environment. In addition to COX-2 is also increased in these patients, which would result in increased prostaglandin, which again, in addition to causing inflammatory process, which will again stimulate aromatase to increase estradiol level in the environment, microenvironment. It is not only the mechanism by which the cells are proliferating, but basically this ectopic endometrium is resistant to natural apoptosis. So BCL gene is actually altered in these patients. That could be a reason for continuous proliferation of endometriosis. So basically it is high local estrogen production, high local prostaglandin production, and also resistance to the action of progesterone had been documented in these patients. So increased prostaglandin can cause increased cytokines, which is really needed for adhesion, increased matrix metalloproteinase, resulting in invasion of the lesion, and increased chemokines and altered natural killer cells, macrophages, which are really altered scavengers in this scenario. So whatever may be the mechanism to initiate the process, retrograde menstruation, metaplasia, whatever may be the initiating factor, but ultimately immune dysfunction is really needed to continue this process. And latest one is oxidative stress because of infection and inflammation, and these tissue is resistant to apoptosis, so it can proliferate to a greater extent. So various theories like reflex theory, Mayer's theory, Mullerian rest, and inflammation genetics, epigenetics, lymphatic spread and vascular spread ultimately results in endometriosis. So in these patients, we can always see altered NK cell cytotoxicity, CD8 cell cytotoxicity is also reduced. In addition to that, macrophages function is not really as a scavenger, but increase the inflammation. So TH1 to TH2 shift is also seen in these patients. So ultimately, all cytokines are involved, which results in inflammation, and COX-2 is also increased in these patients. So ultimately, estradiol level in the microenvironment is higher. So whatever may be the initiating factor, ultimate triggering and modulatory factors are genetic, epigenetic, and environmental toxins also play a role in progressive endometriosis. And when we come to the risk factor, early menarche, late menopause, menorrhagia, delayed childbearing, low parity or nulliparous, higher social economic class, and first degree relatives, thin individual with obstructive Mullerian anomalies and environmental exposure to dioxin will also lead to endometriosis. So to conclude, endometriosis is a complex disorder with long years of debilitating consequences, but poorly understood triggering factors, essentially an endocrine and immunological dysfunction resulting in a profound local inflammatory condition. So depending upon etiopathogenesis, we have various therapies, immunomodulator therapy and anti-estrogen therapy, which would be really useful for the patients. Thank you.
Mandakini madam? Hello? Yeah. Mandakini ma'am? Okay. So thank you so much.
1 minute, one minute.
Mandakini ma'am is there?
Thank you,
Yes,
Kalpana,
yes,
for
yes.
that excellent lecture. And I think there will be many questions, I think, in the chat box.
Yeah.
And thank you very much, because I'm told to keep it short.
Yes.
Thank you.
Thank you so much, madam. Thank you so much. I invite Professor Tusharkar sir to be introducing Dr. Kuldeep Jain sir.
Madam Tushar sir is yet to join.
Okay.
We can ask Dr. Fessy.
Yeah, Dr. Fessy? Dr. Fessy? Can we see him, ma'am?
He was here.
Okay.
Dr. Fessy, are you here?
Archana Basir ma'am is there.
Yeah.
Archana Basir,
Dr.
madam?
Can you?
Here. Yes. Hello.
Madam, you inviting you to introduce Dr. Kuldeep Jain sir.
In brief.
Archana madam,
Hello.
please unmute yourself.
Hello.
Fessy, yeah. Fessy,
Hello.
Okay.
Can you hear
Yes,
me?
yes,
Yeah.
sir. Dr. Fessy sir, please go on.
Okay.
Please introduce Dr. Kuldeep Jain sir.
Okay.
Okay.
You want me to introduce Dr. Kuldeep or Dr. Fessy is introducing?
You can take over Sonal Panchal, Archana.
Fessy sir.
Yes. Tell me.
Yeah.
I have to introduce or Dr. Sonal will do?
You introduce, sir. Archana madam can take up with Dr. Sonal madam.
Okay. Then it is my proud privilege to introduce Dr. Kuldeep Jain. He is the director and IVF specialist of KJ IVF laparoscopy surgery. And he has been, I'm not reading all the things. He is the, he was the IFS president and is a member board of IVF, International Fertility Federation of Societies from 2016 to 2019. And he was the AOGD Infertility Committee chairperson and chairperson International Exchange Committee of the IFS. And he has served in FOXY in different roles last 35 years and was endometriosis committee chairperson. That is, we have got an array of endometriosis committee chairpersons here. Today, Asha madam is there, Dr. Anu is there. And also Ramani madam is also there. And I think so we have got the right person to speak on the topic. Kuldeep Jain sir, are you there?
Yeah. Thank you, Fessy, for your kind words. Let me just share my slides and then I will start. To begin with, I will like to thank the organizing team led by Dr. Parul, Dr. Asha and Dr. Renu and the whole team to organize this wonderful course. I think that is the need of hour, and ICOG is taking the lead in preparing the young gynecologist for this troublesome disease. I may say it is a troublesome because there are a lot of dilemmas and controversy when we speak of endometriosis. I can't see my slide. Just bear with me.
I think sir is a nice right person to speak on this endometriosis staging of endometriosis and EFI, because that need a clarification compared to the routine gynec practice. When you come into infertility, there is a lot of difference, and so he's the right person to speak on the topic.
Can you see my slides?
No, sir.
Just
Maybe you did not press the share button.
We are not able to see, sir.
yeah, I am just searching my place from where I had to.
Sir, just opening the PowerPoint and then.
I have opened it. Just bear with me.
सर जूम की स्क्रीन पे आके आपको शेयर बटन दिखेगा ग्रीन कलर का, आप जूम के स्क्रीन पे आइए पहले.
It is open actually, but it is not getting shared.
No, don't make it slide share. Just open it and keep.
I have opened it.
जूम की स्क्रीन पे आइए सर.
Then don't make it slide share. Then go to the Zoom.
Hello. Okay.
जूम की स्क्रीन पे आ गए सर.
Dr. Sonal is ready. Sonal Panchal.
Yeah, if she is ready, I think she can continue. Let me
I think
open my slide.
Archana madam. Archana Baser ma'am.
Yeah, can you display the CV of Dr. Sonal? Nilima, Gauri? Sonal said she is very much here.
Archana Baser madam.
Hi, I'm here.
Yeah,
Yes,
yeah.
sir. You can.
Kuldeep sir is just looking into some issues with the slides, so we can just
I
introduce
request
Sonal madam.
she's willing. Yeah.
Hi, can I introduce my dear friend Sonal?
Yes.
Yeah,
Yes.
we are calling you.
Hi, it's my proud privilege to introduce my, the great academician, and I think Sonal is a great friend and she's a good teacher. Teacher par excellence. Anyone who wants to do sonography, gynec sonography, I think if they have not seen Sonal working or have not observed Sonal, I think they're missing out something, because Sonal is one who is passionate teacher. Sonal is consultant at Dr. Nagori's Institute for Infertility and IVF, Ahmedabad. She has PhD in ultrasound in gynecology and infertility. She is professor at Dubrovnik International University, National Academic Director of Ian Donald School. She is Director, Center of Excellence, Ian Donald School. She is National Advisory Board member of International Infertility Medicine with JP Publication. She is reviewer of Journal of Human Reproduction. She has published 45 papers in national and international journals. She has delivered more than 800 lectures, contributed in and authored several books, more than 120 chapters, and she's keen interest in infertility, gynec ultrasound, and 3D, 4D ultrasound. Whenever we are stuck with any of our ultrasound, we have Sonal's book in our library to look at, or Sonal is a great friend in need. We call her and she will always respond. So the podium is for you, Sonam. So everybody is eagerly waiting to hear you on endometriosis, ultrasound in endometriosis.
Thank you very much, Dr. Asha, for those very, very kind
Gauri,
words.
Sonal ma'am ko post
Sir,
karo,
it is the host has disabled the participant for the screen sharing. So please
yes, ma'am.
allow me.
Gauri, please. Hello,
Hello.
Yeah. Please,
Sonal
please
Panchal
allow
को
me.
post करो.
Yeah, na ma'am.
Sonal Panchal.
हाँ. हाँ कर दिया.
Thank you very much. Thank you. Yeah, thank you. Thank you very, very much, Archana, once again for those very, very kind words. And thank you very much, Dr. Asha, for inviting me for this. It's always pleasure meeting all the old friends. And yeah, it is a pleasure participating in an academic session always. Yes, imaging in endometriosis was what was given to me, but I'm going to concentrate more on ultrasound today because MRI is probably not my field, not a field of my expertise. And ultrasound has so much to offer that I will limit myself to ultrasound. We all know by definition what is deep infiltrating endometriosis, and it is an endometriotic lesion which invades the peritoneum more than 5 millimeters. And it presents predominantly with nodular myoproliferative lesion interspersed with sparse amount of glandular and stromal tissue of the endometrium and microendometriomas. So this is what it basically is, and it also leads to, therefore, sterile inflammation. So if you look on ultrasound, there are endometrial implants. There are signs of muscular hypertrophy and fibrosis and adhesions. And then it may or may not show blood supply depending on how much hyperemia is there. So this is absolute basic of what is seen on ultrasound, or what you expect on ultrasound when you are sitting to diagnose endometriosis. You can do an abdominal scan, a vaginal or a transrectal scan. And it is all these routes which would help you explain the symptoms of the patient depending on where the lesion is, map the disease exactly, and its extent and the severity is what ultrasound can do for us. Ultrasound being a dynamic examination, it is of much more help probably to locate the lesions which are generally not thought of. That means all atypical locations of endometriosis, and ultrasound is the modality of choice. Yes, it is true that when you do an abdominal ultrasound, that's when it's very difficult to assess the pelvic lesions, because we know that the pelvic structures are quite far from the probe and the resolution is poor. But for the abdominal endometriomas, endometriotic patches, and also for the skin lesions or the scar lesions, abdominal approach is much better. Though transvaginal has a huge application when it comes to the endometriotic lesions in the in the pelvis anywhere. I would not even name the locations because we know, we really have a short time to discuss all those things which you all know. I'm not going to repeat. I'm just going to tell you what I think we should all start knowing. So what are the basic steps? The IDEA guidelines, the International Diagnosis of Endometriosis, says that you do a routine evaluation of the uterus and the adnexa. You look for adenomyosis and endometriomas. You look for any soft markers, which is pain on probe pressure and mobility, so adhesions. You look at the pouch of Douglas, especially for the sliding organ sign, which would tell you there are no adhesions. And you look for the lesions, the nodules in the anterior and the posterior compartment. So going to it very quickly, start your scan from the moment the probe is right on the introitus, and observe the movement of the layers over each other. Which are those layers that we want to observe? The urethra, the bladder, the posterior urethral wall, the anterior vaginal wall, posterior vaginal wall, vaginal canal, and we have a rectum here. So we have to observe the sliding of the urethra on the intervaginal wall and the rectum on the posterior vaginal wall, for which you can push in the probe and push out the probe again, pull out the probe again, and then you touch the cervix. So that is the first thing that you do. As you approach the uterus, you will be in the midline, and you have to be very sure you are not going to rotate your probe at that point of time, and find out whether the uterus is truly in the mid-sagittal plane, or it is deviated, or it is twisted, which can be found out by absence of the mid-sagittal plane in the when your probe is in the mid-sagittal plane. So absence of the mid-sagittal plane of the uterus when the probe is in the mid-sagittal plane, which tells you the uterus is deviated, and the part of the mid-sagittal plane seen, that means either the endometrial cavity or the cervical canal seen, not the entire mid-sagittal plane, would tell you it is twisted. And these two are very important because endometriosis will lead to malposition and adhesions of the uterus very commonly. Scan the entire uterus, span it from one side to the other side in the longitudinal plane as well as in the transverse plane, to look for all the layers, especially the junctional zone, which is very important to us because it's junctional zone, which the irregularity of the junctional zone, the inaccessibility of the junctional zone, the obliteration of the junctional zone are the signs which are most important when you are up to diagnosing the endometriosis. Check for, we will see all these positive signs on the images, but we are just at the moment we are going through the process of examination or assessment for the endometriosis. Look for the mobility of the bowel lobes on the cervix, over the cervix. That tells you if everything is mobile, that means there are no deep endometriotic patches which are large enough to cause symptoms. Confirm the mobility. Once you have finished the assessment of the uterus, move your probe towards the ovary, and even for the ovary, check for the mobility apart from you. So those are the things that you are going to move to the pouch of Douglas and look for any fluid collection. And not only fluid collection, when you look at the pouch of Douglas, also try to push your probe deep into the pouch of Douglas, especially in the retroverted uteri. And this retroverted uteri are quite common with adenomyosis as compared to the normal uteri. And see here, you can see a free movement of the probe, and you can push the probe right into right behind the uterus. Here, it's not possible. There's a fluid collection also, and it feels like obstruction of the probe, which tells you there's obliteration of the pouch of Douglas, and which is an important sign to tell you there is possibly deep endometriosis and adhesions in that area. So that is the basic way of examining it. Coming to the positive signs very quickly, adenomyosis, you all know very well, it would be an enlarged uterus, which may be symmetrical or asymmetrical, globular in shape, would be showing heterogeneous and myometrium because of either hyperechoic dots or maybe hyperechoic lines. You may also see very tiny anechoic cystic lesions, as you're seeing in this image. Anechoic cystic lesions, which may be myometrial cysts. You may sometimes see hyperechoic islands, or you may also see, a very irregular margin of the junctional zone. Not only the margin, but the thickness also varies into the into the affected parts of the junctional zone. So that those are the signs on 2D. Apart from that, you would also get an abnormal curvature, a reverse curvature of the fundal endometrium. By what do you mean by reverse curvature is that if it's an anteverted uterus, it would turn posteriorly, and if it is a retroverted uterus, it would turn anteriorly. So that is what is the reverse curvature of the endometrium, endometrial cavity, which is called a question mark sign. Apart from that, if you switch on the Dopplers, you would see that the vessels, if they are present. Why I'm saying if they are present, not all adenomyosis are always hyperemic. There are some which are hyperemic, there are some which are hypoemic. And if the blood flow is less, in this case is these are the adenomyotic uteri, which will not respond to the medical line of treatment. So vascularity may vary, but what is in common? In common is that all the vessels are larger in diameter than the normal spiral vessels one, and instead of the normal arrangement of the spiral vessels, which is parallel to each other and perpendicular to the endometrium, these vessels are curticulated. So those are the signs of adenomyosis. Diagnosing endometrioma, because that is a part of still a part of IDEA guideline. Yes, we all know that ground glass echogenicity, which is very specific, and IOTA also calls it identification sign for the diagnosis of endometrioma, but not all endometriomas would be ground glass. What is more specific for endometrioma is you are seeing hyperechoic flex in the walls. You are seeing hyperechoic flex in the walls. They are because of hemosiderin or cholesterol. You may sometimes see a fluid level, wherein you would see hyperechoic layer, which is situated more posteriorly, as you are seeing in this image. It is the hyperechoic layer, which is posteriorly, which is debris or whole blood, whereas you may see the serum floating, which is anechoic. You may sometimes also see the acoustic streaming sign, as you're seeing there. And if you put on a Doppler, you would see short course vessels. That means the vessels, they come and approach the walls of the endometrioma, but they do not run along. These are the signs that you would see on ultrasound in general, but very important is that endometriomas can be differentiated from other lesions by one, of course, presence of adhesions, which may always not be there, but what is always there is pain on probe pressure. So whenever you have lesions, sometimes the echogenicity of the endometriomas may be atypical, but what is very essential is that if you have a doubt, push it with your probe. If the patient says it hurts, that means it is an endometrioma rather than anything else. Endometriomas, because of adhesions, may also lead to blocked tubes and therefore may often lead to hydronephrosis. So hydronephrosis, of course, generally we think of about inflammation, but in endometriosis also the hydronephrosis is very, very common. You may see free fluid in the pouch of Douglas, and sometimes you may find such cystic lesions, or sometimes you may also find adhesion bands or tissue tags floating, and these may be signs of superficial endometriosis, and we'll see some more images later on. So basically, if I'm going to talk about deep of infiltrating endometriosis, what am I supposed to see or look for when I do the scan in different locations to locate endometriosis in different locations? It is an irregular hypoechoic firm mass, which is tender on probe pressure. It will have, so that is what is it? It will have hyperechoic margins, and it would also show adhesion bands, as you're seeing here, extensions. It has a poor vascularity. It may show some flecks of color, but it is not really vascular. And there is on one of the ends, on both, sometimes on both ends, sometimes on one of the ends, you actually see tapering, which is called comet sign, and you would also sometimes rarely see cystic lesions inside. But fixity within the between the layers, whichever layer is involved. Say, for example, if the bowel is involved, posterior-vaginal wall with bowel, of its urethra is involved, and urethra with the anterovaginal wall, you would see there's adhesions and in lack of movements between, which tells you, yes, it is an endometriosis.
I'm sorry to interrupt you, but your time is up.
Sorry? You said 2 minutes of time, so just tell me when I'm finished, because endometriosis is truly a very wide topic, and I'll just finish whatever I can. Okay? So, but don't hesitate to tell me stop. I'll stop there. So the posterior compartment assessment, of course, you would check for the mobility, and after you have checked for the mobility, it is essential that you would angulate your probe posteriorly and allow to slide in, where you would trace the entire muscularis, and that would lead you to a lesion in the form of thickening, irregular thickening of the junctional zone and of the anterior muscularis, and pain on probe pressure with tiny hyperechoic spots and the hyperechoic margins. So that is what is we are looking for as we are tracing the entire anterior muscularis, and that is how you examine. And it is here, if you can see, there is lack of movement between the posterior vaginal wall and the bowel, and you're seeing here the irregular hyperechoiculation, pain on probe pressure. That tells you, yes, it is definitely, you are seeing it here again. That tells you, yes, it is endometriosis. So it is a transvaginal scan, which is very useful. You can do a gel vaginal sonography. You can also trace the lesions. You're tracing one more lesion here also, but I think not to waste time. There are lots of clips that I could have shown, but I'm sorry. The time is really short. Okay, anyway. So you are seeing this again, hyperechoic stretch lines, which tell you it is an adhesion and it is endometriosis. It is also typically described as red Indian head sign. And in the transverse section, it would look as a signet ring sign, sliding organ sign, which we have talked about. Again, is seen there. Comet sign is this sign. This is called the comet sign here. You can rule, I mean, the malignancy is to be differentiated because endometriosis involves narrows down the bowel, but it involves the wall of one side, whereas we know malignancy constricts from all the sides. So that is the major difference between the two. All the different signs that I've told to you about and shown you are given in the books. So you can just go through it and maybe try and remember them whenever you can. Obliteration of pouch of Douglas is what I've told you already. Triangular sign is collection of the fluid posterior to the lower uterine body. I hope I can see it, which can be elicited by in and out gentle movement of the probe, especially in cases of retroverted uterus. And you're seeing the tiny collection of fluid here, which tells you the pouch of Douglas may not be obliterated, but it is always the firmness that you feel will tell you. You have to locate the lesion, and you can locate it based on one, distance from the anal verge, and second, from the level of the lower end of the cervix or the external os. So that's how you're going to do it. You have to angulate your probe posteriorly in the midline and go deep into the posterior fornix. And as you go deep into the posterior fornix, you'll see the posterior vaginal wall and the peritoneum overlying. And as you span the probe from there, you would see the thickened hyperechoic band, which is the uterosacral ligament. So you can also find tiny hypoechoic areas in the uterosacral ligament, and that would tell you there are nodules of endometriosis there. What is very important, till what I talked to you about, is in the uterosacral, it's the uterosacral ligament where the lesions may still be seen on your laparoscopies, but when it is a rectovaginal septal endometriosis, which is below the peritoneum, this is where the laparoscopy cannot reach. That's where the ultrasound can reach, and that is where it becomes a game changer truly. We will probably, because of short of time, am I really short of time? Or I have 4 minutes.
Already too late,
Yes,
Dr. Sonal.
time is up.
Already much beyond your time.
Okay. Then I'll stop
sorry,
there.
I know an excellent speaker.
We will not discuss anything about anterior compartment involvement. And that's it. Thank you very much.
Thank you so much, Sonal. I know you're an excellent speaker and you know so much, need so much more time. Some other
That's
time
okay.
we should do that. Thank you so
Yeah,
much.
I thought that 15 minutes, but it was cut to 12 minutes. So I'm sorry.
Thank you so much.
Thank you, Sonal Madam. And I wish we could listen to you more and more, and that would go on. Thank you so much. And I invite Dr. Faisal Lewis sir to introduce Dr. Kuldeep Jain sir.
I think I will. I'm
Okay,
ready.
sir.
Yeah.
Okay.
So I will just go on the slide sharing. It is not coming here. Unfollow. Can you see my slides?
No, sir.
सर आपको जूम पे आके शेयर स्क्रीन करना है.
No, I am sharing, but my slides are already there, but I don't know why they are not
स्क्रीन पे
getting
आके
shared.
आपको शेयर स्क्रीन करके वो स्लाइड्स क्लिक करनी पड़ेंगी एंड देन शेयर करना पड़ेगा.
We have
we ask Dr. Parikshit?
Yeah,
And we
I
can,
think Parikshit sir is there. Pesi sir. In the meantime, again, we'll just be back.
And introductions, the introductions can be really brief.
Yes.
The delegates are also requesting. We just tell the name of the person, that's enough, because everybody knows the
Pesi sir.
speakers.
Can I, in the meantime, can I continue the introduction, and probably I will be able to open. So I think that will minimize the timing. Can I do that?
Are you able to open it, sir?
Yeah, it is open in front of me, but I am not able to share. So I will just start.
That green, can you just go to Zoom? That green button is there, means share.
No, sir has already tried that.
I have tried everything. I don't know what is happening. I am not able to see my slides when I am sharing.
Send the slides to you, Nilima or Gauri. You can share it from your side.
Because we lost 5 minutes in this.
Yeah, I know.
So just email that presentation to ICOGoffice@gmail.com. We will
I
share
think that will be better, sir.
Meanwhile, yeah, next
We will
speakers
start
can.
with the Parikshit.
Next.
Yes, sir. Yes, sir.
I think that is okay.
Okay.
Pesi sir, please
Yes,
introduce Parikshit sir. We'll have the CV.
Parikshit's slide. So, okay. It is my privilege to introduce to you Dr. Parikshit Tang, who is not only the consultant Ashwini Veterinary Surgical Hospital and Endoscopic Center and IRT Center, Mumbai. He's and he's also the honorary professor of Pacific Medical College, Udaipur, and also the consultant assisted reproduction of 16 centers. And at present, he is the treasurer of the FOXI. And he was the chairperson of Safe Motherhood Committee of FOXI from 2014 to 17. And he's an examiner for MRCG Part 3 and managing committee member of Mumbai Society. And he done a lot of publications and awards. And he will be talking about medical management of endometriosis current scenarios. Over to Dr. Parikshit.
Parikshit sir?
He's not seen.
Oh, he's there. He's there. Parikshit sir?
Yes, he's there.
Yes, he's
Can you
there.
somebody call him?
I'm just calling him. He's not picking up the phone, so okay then. Kuldeep Chand sir, your slides are sent, sir. Parikshit sir is not picking up the phone, though he is joined here. Asha madam. So
I know, I too tried. He's not picking up the phone, yes. This one
Go
is not
ahead
ready,
with
right?
the next speaker. See,
we'll
we
move
are
forward,
late.
sir. Yeah.
Yes.
We have Dr. Sonal with us. I think we can move on to the next section. So I'll introduce the next, we move on to session 2, and I introduce the chairpersons for the same, Dr. Kundan Ingle, who is the chairperson of FOXI Infertility Committee 2022. He's the director, Nirmiti Clinic, Center for Assisted Reproduction, Pune, and he is also presented his first original research paper in the 6th COGI World Congress at Vietnam on the use of GCSF
is not here.
subcutaneously. So welcome to you, Dr. Kundan. And I also welcome Dr. Lakshmi Shirikhande, madam, who is the Medical Director, Shirikhande Fertility Clinic, Nagpur, Chairperson, ICOG 2223, a vibrant year, National Corresponding Editor, Journal of OBGYN of India, Jogi and Publications 20 National and 11 International. Also, welcome to you, Lakshmi, madam. And I would also introduce the next chairperson, Dr. Gaurav Desai, who is a gynec endoscopist and fertility specialist. He is assistant professor, SAIT GS Medical College and King Edward Memorial Hospital, managing committee member, Mumbai OBGYN, 12 national and international awards to his credit in OBGYN. And welcome to you, Dr. Gaurav. And I also welcome Dr. Prateek Tambe, who is an ART consultant and gynec endoscopic surgeon. He is the chair AMOG's Endocrinology Committee, governing council member ICOG 2122, a recipient of 16 MOGs and 8 Foxy Prize Awards to his credit. So welcome to you, Dr. Prateek. With this, I invite, I think Dr. Kundan is not there, so I invite Lakshmi Madam to introduce Dr. Sonal.
Yeah. Thank you, Ritu. It's a pleasure to invite Dr. Sonal Kutadawala. She is consultant gynec and ART specialist at Ahmedabad, Kutadawala Women's Clinic, and she is trainer for endoscopic surgery. She is chairperson of poster committee of AICOG way back 2017, and I know she is the silent worker with our chairperson Dr. Parul Kutadawala. So I invite Sonal, the floor is all yours for adolescent endometriosis.
Thank you, madam, for that kind introduction. And let me thank the ICOG team, Dr. Asha Rao and the team for inviting me to join this webinar. Thank you. So, hello. So, sorry, just 1 minute. We all know that endometriosis as such is an enigma. I think my half screen is seen, right? I'll just
we can see only
change that.
And somehow it has got
Yes, 1 minute. Pain in lower abdomen of at least 6 months. Dysmenorrhea, which is not responding to our routine NSAIDs, and cirrhosis, oral contraceptives. What is important is that 25 to 38% of adolescents with chronic pain end up with diagnosis of endometriosis. The risk factors, as previous speaker has already said, it is increased exposure to menstruation, that is early menarche and heavy long periods. Genetically, it was found that 6.9% of affected individuals had some kind of genetic history of first degree female relatives having endometriosis. Lean body size, obstructive Mullerian anomalies for the obvious reason of Sampson's theory, and presence of certain autoimmune diseases, which is found that SLE, these people have more SLE, Sjogren's disease, and sometimes migraine is also more common with this thing. So when we find these two combinations, chronic pelvic pain with these things, we have to think about endometriosis, and other environmental factors also are there. Very interestingly, I found that neonatal uterine bleeding, which is endometrial response to withdrawal of progesterones, we know at the time of delivery. Even though only 5% of newborn girls get diagnosed with NUB, 25% of them may experience occult bleeding. And most neonates' endometrium is basically resistant to progesterone. But when there is fetal distress, there is placental insufficiency, insufficient blood is supplied to placenta, this fetus becomes hypoxic. Decidualization of the female endometrium and sensitization of the fetal endometrium to progesterone are promoted. And during puberty, when estrogen production initiates, the endometrial progenitor cells are reactivated, which promotes angiogenesis. And we know that basic angiogenesis, more angiogenesis is considered to be a primary factor of endometriosis recently. So ultimately, recurrent implants, bleeding, and endometriosis formation. So we have to think about the history of neonatal uterine bleeding also. What is more concerning is that the delayed diagnosis of endometriosis, yes, up to 8 to 12 years, because we know that everybody feels that, okay, first year it's not paining, but later on secondary, severe pain during periods, dysmenorrhea, it is very common. It is accepted as a norm by elders. Often general practitioner and pediatricians, they just dismiss it as a symptom. But careful history taking and reviewing the symptoms, especially the abdominal discomforts like dysphagia and all that, low back pain, they all are very important in our future diagnosis of endometriosis. And pain, we have to ask for menstrual history, age at menarche, and the pain diary, because sometimes this kind of differentiation of symptoms can also lead us to the future diagnosis of endometriosis. Pelvic examination, we know in most of the adolescents are young, unmarried, and not sexually active, but we can do per rectal examination, and sometimes even pelvic examination is also possible in these patients. Madam has already previously said about the all the biomarkers of chronic pelvic pain and why does it occur. So I'll skip this, but what I really want to say that we all know that primary dysmenorrhea, when we find it is functional, we cannot find the cause. But secondary dysmenorrhea, when we are finding that cause, when we get in some kind of idea and diagnosis that this is the reason for dysmenorrhea, endometriosis tops the list of secondary dysmenorrhea. TVS, Madam Sonalben already said about optimum diagnosis, but let me tell you that in teenage, when we have very small transparent lesions, these are very difficult to detect with sonography. But yes, chocolate cyst or adnexal masses, or if there is a nodule, then that can, sometimes if we really want to avoid laparoscopy, MRI can be helpful. It shows thickening of peritoneum, thickening of uterosacral ligament, partial obliteration of POD, and fixation of ovary, which could be the later thing. A small size focus of hypointense signal in retrocervical space can be picked up with MRI, which cannot be picked up with transvaginal sonography. So this is the graph shows that these are the various percentage which can be seen, endometriotic lesions can be seen through MRI. But what is important is we can see in this graph that diagnostic accuracy of MRI is much earlier. We can diagnose it quite earlier than the routine curve. So that is important when we are planning to diagnose endometriosis. In my practice, I have done this, that trial of medical therapy with just one dose of single GnRH agonist. Sometimes when you really do not want to go for laparoscopy. In patients with chronic pelvic pain and high probability of endometriosis, age around 18 years, we have to take the consent of patient and relatives and tell them that, with this, if pain completely goes, which becomes hypoestrogenic stage of a body, then we can reasonably say that this can be endometriosis. Newer diagnostic tests which are less invasive, they have come up, higher plasma levels of all these biomarkers, lower levels of TNF alpha. Detection of nerve fibers in endometrium, especially in menstruation, that was found to be high in cases of endometriosis with pain. But next generation sequencing has now come, and menstrual effluence, I think this is still in pipeline, and maybe in 2025 this test is going to come. But the test which has already come in the market is the EndoTest diagnostic saliva test for endometriosis. It is a now non-invasive new saliva test for reliable and rapid diagnosis for all types of endometriosis. It is do it yourself home saliva test, relies on next-gen sequencing of microRNA present in saliva and on the use of artificial intelligence for analysis. The results are available in 4 weeks. Patient is required to spit into a tube that is sent to the laboratory for testing. An examination of microRNA gives very accurate results. But here the problem is this is pretty expensive. Recently, I talked to them in the Zivia, which is a French company who has come up with this test. The cost in our Indian rupees was around between 60,000 to 1 lakh for single test. For them, when laparoscopy is not very expensive, very expensive in European countries, it's okay. But I don't know, in our country, we still consider that if you are really sure and you want to be, gold standard diagnostic test is laparoscopic finding. And we have seen that when there is chronic pelvic pain, endometriosis is found to be in 38 to 45%, and rest of the things are there. What are the lesions here? The lesions are, most of the times, this is a 16-year-old, the red lesions, there are the peritoneal windows, and typical phlegm-like lesions are there in broad ligament and perivascular peritoneum. These are the patients who have severe pain, but we have not found any reason. These white foci, they are also kind of same diagnosis, for endometriosis, but mainly the, 1 minute. Okay, the red lesions which are seen here, they are really diagnostic of endometriosis in adolescents. The black lesions, they come after around 10 years or at least more than 7 years. And this usually we see in adolescent are the red lesions. So when we come to the therapy, primarily we all know that non-steroidal anti-inflammatory drugs, that is the first line for all kinds of dysmenorrhea. Then next comes the estrogen progesterone combined therapy, cyclic or continuous use, which causes again quite a few patients get benefited for dysmenorrhea from there. But when it doesn't respond, or if we do not want to give estrogen, then only etonogestrel implants or oral progestins can be given. LNG-IUS is the drug, but let us talk about it. Newer progesterone, Denogest. Progestin indicated as a monotherapy at an oral dose of 2 milligram per day for patients with endometriosis. It is highly selective progesterone. What is there is suppresses estradiol only moderately, and in a 52-week multi-center study of adolescent girls, Denogest 2 milligram per day was effective in relieving symptoms of pelvic pain, dysmenorrhea, dyspareunia. There was slight reduction in bone mineral density, but most of them recovered 6 months later. Newer progesterone, dydrogesterone. These days it is in, we have started using it 10 milligram 2 to 3 times a day. This Orchidia trial showed a really good response when it was used continuously or as a day 5 to 25 for continuously for 6 months, and it gave very good results. These days we have come up with dydrogesterone sustained release tablets. So let us see whether we can, with just one tablet, if we can, our patients are benefited or not. The LNG-IUS, as I said, we'll talk about. I feel that this is the drug for all kinds of menorrhagia and abnormal uterine bleeding. And when endometriosis is there, because of the endometriosis, there is severe pain, and a patient gets benefited with this, and especially to prevent the recurrence. Delivering LNG to uterine cavity at a steady rate of 20 microgram per day. And in what I feel is that when we are really sure that this is going to be endometriosis and we are going for laparoscopy, we should ask the patient beforehand that if we find this and you are not planning a pregnancy, she is still unmarried or something, we can put an LNG-IUS simultaneously to benefit these patients. Other therapy, RU486, aromatase inhibitors, selective estrogen receptor modulator, progesterone, but these all have not been tried in adolescent age group yet. Immunomodulators and anti-angiogenic agents are going to be the new molecules, which I think Dr. Parikshit is going to talk about. Gabapentin, valproic acid, and oleoproin, which is then got from the olive oil preparations and the plant of that. That was also found some response. Magnetic hyperthermia, which removes disease-causing tissue. Its method involves delivering magnetic nanoparticles that accumulate in endometriosis tissue. When alternating magnetic field is applied, the nanoparticle generate heat, causing endometriosis tissue to die. These are all the therapies which are not in practice right now, but they are for adolescents only, because rest of the things we are using for adult endometriotic patients. Post-surgery, we have gone for, we have given laparoscopic surgery, done laparoscopy, and we have cauterized all the endometriotic foci. Post-surgery hormone therapy is must. Once endometriosis is diagnosed, progesterone, especially Denogest or Denogest plus estrogen. Dipomethylprogesterone not used for longer time because of bone mineral density problems. GnRHA Leupride depot is for 3 months, or if we have to continue, if there is recurrent pain, then we can do add-back therapy where we give GnRH along with ethinyl estradiol 625 milligram, or we can give norethindrone along with it. Aim is to prevent significant bone demineralization, but enough to prevent growth of endometriotic tissue. So we get both the benefits, and patient is pain-free, which is our main aim. And we prevent the further growth of the endometriosis. A baseline bone density assessment after 6 to 9 months is must when we are using GnRH agonist.
Time is up, ma'am.
Okay, just 1 second. Last, sir. GnRH antagonist, no studies in adolescents are seen. For recurrent pain, we can give GnRHA therapy with monitoring of this. So in summary, we can say that up to 80% teen girls with this thing, chronic pelvic pain, we have to think about endometriosis. Early diagnosis will be helpful. Laparoscopy with biopsy is still needed to confirm, but non-surgical methods are increasingly used for diagnosis and therapy. And the final answer is sometimes it is very severe and patient has to go for all surgeries. Then we have to explain it to them about role of egg freezing for their future pregnancies. Anyway, thank you very much.
Lakshmi, madam.
Thank you so much, Sonal. It was a wonderful talk with so much practical take-home messages. You covered the diagnosis and the management. And yes, the take-home message for the audience, which is very, very practical, that any adolescent girl who's coming to you with chronic pelvic pain, Just don't brush it off that it's because of your exams or because of your stress or it is something else. Please investigate her. She might be having endometriosis. So excellent talk, Sonal. Thank you so much.
Yeah, thank you, Lakshmi madam. And we have Parikshit sir with us. And by the time Nilima, just be prepared with Kuldeep Jain sir's slides. He's already shared. So please unmute yourself, sir. Kuldeep sir. Nilima, just check your slides have reached you. And Parikshit sir can take his presentation, sir. Over to you, Parikshit sir.
Sure.
Hello, can I present or Parikshit is presenting? Okay.
After Parikshit sir, she'll put the slides into this thing, sir.
Okay,
Just
no
after,
problem.
sir.
Yeah,
Right,
no
sir.
problem. Yeah.
So many thanks for this kind invitation, and I've been asked to really stick to the time, which is at a premium today. So considering this, let's get on with the work we have at hand, and that is to explore the medical management of endometriosis. Now, thanks to the computer glitch, some of the topic has been already covered by Dr. Kotadawala. So thank you very much, ma'am, for that. And we know that, from the earlier understanding of endometriosis in the 1960s textbook, which was a very rudimentary kind of understanding, we have moved to a grand unified theory of endometriosis, which encompasses anatomy, pathophysiology, the microenvironment, genetics, so on and so forth. So ultimately, we have a much deeper understanding of what endometriosis is. And today, there is a lot of emphasis on biomechanics and the biomolecular theories and the biomolecular aspects of not only treating but even investigating endometriosis. Typically, endometriosis comes as a triad. There is dysmenorrhea, dyspareunia, and infertility. So for the purpose of today's discussion, we'll take pain as one component and infertility as another component of endometriosis. And each and every guideline, you can refer to the ESHRE, to the Canadian one, ASRM. What they emphasize is that endometriosis is a chronic disease. Irrespective of how good a surgeon one is, please don't think that I have operated and I have removed all the lesions, but endometriosis has a propensity of coming back. And therefore, medical and surgical interventions have to be used to suit that particular individual's needs at that particular time in her life. And for pain, there are various options which have been talked about, and we'll get into them in the next few slides. So let's consider, there's a woman who comes with pelvic pain and pregnancy has been ruled out. Of course, if it's an acute situation like a torsion or an inflammatory infective mass, okay, then you're more or less going to generally resort to a laparoscopic evaluation and surgical treatment. But if it's not acute and you suspect that the problem is endometriosis, as it often is, what are you going to do? You're going to give some kind of trial of medications, see whether this is giving a good response or not. If not, go to the next level of medical treatment. And then if nothing else is working, then you're going to think about a laparoscopy and doing something surgical. So today, medical treatment is all about creating pseudo-pregnancy by progestational agents, pseudo-menopause in the earlier days by danazol, now today by GnRH analogs, and the use of certain disease modifiers. So these are the three broad categories into which the options for medical treatment fall. Which are the ones which are effective and clinically proven? It's danazol, dydrogesterone, non-oral progesterones like Depo-Provera and Mirena, and the GnRH agonist Depo. Effective, but we don't have that much of experience, Dynogest. And under research, there are lots. There are aromatase inhibitors like anastrozole and letrozole. Gabapentin has been spoken about, and even selective progesterone receptor modifiers like ulipristal. So the number one choice, almost inevitably, considering the acceptability, the cost, etc., is going to be combined oral contraceptive pills. And the low dose pill is what you're going to prefer. That's a 30 microgram pill. It's quite safe in adolescents. Menstrual pain improves significantly in at least 50% of the people whom you're going to treat. And continuous use may have an edge over cyclical use, because why do you want to give this woman menses and make her miserable every month? Forget it. Just let her have one period in 3 months or so, and you can go on like this for a very long time. The second choice is GnRH analogs, and especially in, so they are effective in all endometriosis related pelvic pain. It may be dysmenorrhea, dyschezia, dyspareunia, everything responds. And in fact, many authorities think of this as an empiric diagnostic test. So if the woman gets better with the GnRH analog, you can conclude that this chronic pelvic pain has a significant endometriosis or adenomyosis component. Usually, the duration of treatment is 3 to 6 months, and this suppresses or reduces pelvic pain. But of course, we know that pain is likely to recur depending on disease activity. She may remain pain-free for a long time after you have stopped using the GnRH analogs, or the pain might come back in literally the next month. The problem also lies with bone loss and the onset of menopause symptoms. And these are usually young women whom you're treating, and they are nowhere close to the age where they're going to experience menopause otherwise. So, which agent to use? And this is from Eshrey. Clinicians are recommended to use progestogens, MPA, Dynogest, Ciprotron, or antiprogestogens like gestrinol. And the guideline development group feels that we have to make the decision based on what is the side effect profile, and especially irreversible side effects or dangerous side effects, which have to be looked into. So putting all this together and considering what is the choice of the woman, you have to come to some decision. Today we are talking more and more about dydrogesterone because in addition to its typical progestogenic properties, it also reduces pro-inflammatory cytokines and reduces oxidative stress, which are believed to have an pro-inflammatory kind of a response, which is what ultimately causes the pelvic pain. So continuous or a prolonged cyclical regime can be used in a dose of 20 to 30 milligrams for, again, any type of medical treatment is going to go on for at least 3 to 6 months. So that's what the Orchidia study also looked at. And there was reduction in pain to the tune of 80-90% of women responding, which is a little more than what you get with the oral contraceptive. But remember one thing, there are certain cautions and considerations that we have to look for. Medical management of pain is usually a temporary response. Please don't think that, oh, this woman has become pain-free and therefore endometriosis has melted away. Sorry, that does not happen. Endometriosis always comes back. But this pain-free time that the woman gets is valuable. Don't underestimate, the importance of giving her this time to think, consider her options, make up her mind as to how to proceed. You can delay surgery. So, say for example, if the woman has associated heavy menstrual bleeding, you can use that to treat anemia, optimize her fitness. For some social reasons, she does not want to get operated, or till a time that definitive surgery is feasible, or the woman just becomes menopausal. In all these circumstances, you can delay surgery, and medical treatment has a definite role in all these circumstances. Surgery may be inevitable, and you may need medical treatment after the surgical therapy also. So all this has to be kept in mind when we are planning a long-term kind of an approach to this woman who has endometriosis. Now let's go to the other part of the diet, and that is infertility. Here, things are very, very clear now in modern times. And this is from the ASRM guidelines. Whereas medical therapy is effective for relieving pain associated with endometriosis, there's absolutely no evidence that it improves fertility. I think this is one sentence which needs to be, absolutely imprinted in the minds of all practitioners who treat endometriosis related infertility. What are you doing when you're giving medical treatment for a woman whose ultimate desire is to become pregnant? You're usually just trying to delay the things. You're giving some kind of, breathing space, but you're not actually allowing ovulation to happen in most circumstances. And therefore, you're not enhancing her fertility. In fact, you're delaying it. So again, Eshe also along the similar lines, in infertile women with endometriosis, clinicians should not prescribe hormonal treatment for the suppression of ovarian function to improve fertility. So very clear. I mean, line of treatment is something else. So if it's mild endometriosis, all suppressive therapies are going to be contraceptive. There's no benefit from doing GnRH analogs, and you might actually end up delaying her fertility treatment or surgery. But severe endometriosis, usually you're going to need IVF, and that's the most effective treatment line that has to be adopted. Now, do non-IVF therapies have a role? Well, best chance of the pregnancy is in the immediate post-operative environment, 6 to 9 months. And this is the time when you can either do a wait and watch or a non-IVF treatment, but for a very short trial. Please understand that if endometriosis recurs or you pass that, best post-operative time, then you're again going to be at a disadvantage, even if the couple opts for IVF. What about GnRH depots? Before IVF, there has been some literature which talks about increased chances of pregnancy. So GnRH analogs have a space only and only in IVF settings, not just by themselves. I hope I'm very clear about this. But there are some problems which are related to fertility when you use GnRH depots. And these are the fact that fertility therapy may get delayed. And anyway, with this deep suppression and an environment of endometriosis, if this woman is a poor responder, she's actually going to have a worse response or need a very high dose of gonadotropin. So it has to be a balanced kind of an approach. There has been talk about dydrogesterone being advantageous because it does not affect ovulation. And this could be an option that we can think about for women who are interested in conceiving, but they face chronic pelvic pain. So that's it from my side. Thank you very much for your kind attention.
Thank you so much, Parikshit sir, for that fantastic presentation. And we had a great insight into it, sir. Thank you so much. And ending it also before time, sir. Thank you so much, Parikshit sir.
Pleasure. Thanks. Thank you.
I can invite Dr. Kuldeep Jain, sir. I think his presentations are ready, so we can have yours, sir. Yeah.
Yeah. Can you see my slides now?
Yes, sir. Yes, sir.
Yes, yes.
Yeah. Okay. So I am really sorry for all mess up, but finally I can present my talk. Can you see my slide?
Yes, sir. We can see them.
Okay. So staging of endometriosis, which is my talk, and its clinical relevance. Ansi, इसको वो करना स्लाइड पे.
सर ये आपने PDF शेयर किया है तो ये स्लाइड शो नहीं होगा.
I think I will continue with this only. Okay. So this quote from Sir William Osler describes endometriosis very nicely. He says, "He who knows endometriosis knows gynecology." Some background is already been given in previous lectures, but I will like to reiterate. It is a disease of controversy and complexity. It is chronic and multifactorial. It is progressive and recurrent in nature. It is not malignant, but behaves like a malignancy, and very difficult to diagnose and treat. Endometriosis, we know that it is multifocal complex disease and can involve pelvic as well as extra-pelvic organs. Almost all organs have been reported to be affected in some of the cases, as far as lung and scar have been affected with endometriosis. And most of the time, in 50 to 90% of the patients, there is an association of adenomyosis with endometriosis. So why do we need to classify endometriosis? The purpose is to know the extent and severity, to plan the management, to prognosticate and counseling, and of course, it is a recurrent disease to follow the recurrence. A reproducible and well-organized classification system is very necessary, not only to clarify communication among physicians, but also to standardize the optimal treatment strategies. What is ideal classification? At present, there's no ideal classification which can fit into all these criteria, which were very nicely highlighted by Adamson in 2011. It should be simple. It should predict response to treatment for pain, infertility, as well as recurrence of symptoms after treatment. It should be scientifically based. It should be comprehensive for all cases. Simple translation from anatomic lesion to verbal description. It should reflect the progression of the disease. It should be clinically meaningful and should have general consensus. At present, we are having multiple classification systems, but unfortunately, none of the classification systems are considered the gold standard because of multiple limitations. Main classifications, slides are not visible. Hello?
Yeah, visible, sir. Visible, sir.
Because I am getting the messages on the chat that slides are not visible. That's why I'm asking.
We can see them, sir.
Okay. So most popular and oldest classification is revised SRM scoring system, which has been there from 1975 and has been revised multiple times. And currently we are using 1996 revised SRM classification. Then there is NGN classification. There is endometriosis fertility index, which is quite useful in our clinical practice. Then there is a pure surgical based classification, that is AAGL classification, and endometriosis foundation classification. Presence of so many classifications means that there is no ideal classification present to us at present time. So let us discuss them one by one. This is most commonly used classification of ASRM, which was revised in 1996. It is basically the score-based classification and has been revised for the clinical point of view. So stages are divided on the basis of the findings on laparoscopy or on the laparotomy, and the points are given according to the extent of the disease. So if there is minimal involvement, then there is only few superficial implant when you are seeing that it is minimal involvement, then mild, which is having more and deeper implants, and then moderate. Now here you can see it is, even if you are having a small cyst in one or both ovaries, your staging becomes stage 3. And that is the clinical dilemma, whether it should be considered if there is a small cyst of 2 centimeters, there is no adhesions and other thing, should it be called as stage 3. So these are the dilemmas associated with SRM classification. And of course, when the points are more than 40, then it becomes severe. And there is another addition here in the last revision, that if there is a POD obliteration completely, then it is given 40 points. This is the classification which considers the depth of the endometriosis implant, less than 1 centimeter, 1 to 3 centimeter, and more than 3 centimeter, and where it is there, whether it is on the ovary or on the tube, and whether it is superficial or deep. So accordingly, the scoring is done, and finally, whatever is the score, the disease is staged. Now, there are a lot of advantage and clinical relevance of this classification. Advantages are it is accepted globally and has been widely used, and it is easy to use, but somehow it becomes little cumbersome when we do use it in our practice, because there are so much scoring, and when the surgeon is operating, ideally an assistant should be noticing the presence of disease, and then only it can be nicely scored. But if you have to recall and then give the scoring, then it becomes very difficult to use this classification. Other disadvantages are it becomes subjective scoring. There is a lot of intra-observer and inter-observer variability. It has been reported like 52% and 38% variability is there. The revised SRM classification stages 1 to 4 are concordant. They are not always indicative of the disease, and the misdiagnosis has been reported. So, and moreover, it is not taking into consideration the deep infiltrating endometriosis, and that's why it is not a perfect classification for endometriosis. Now, second classification, which is used as a supplement to the SRM classification, is Angian classification, and this system was developed in order to provide detailed description of retroperitoneal structure, especially the DIE. It was adapted in 7th conference, and here what is important, it can be used as by imaging modality. So here you need not to go for surgery for using this classification. If you are using a good imaging modality, then you can use this classification. Whole pelvis is divided into compartments, 3 compartments. Here you can see the level 1, level 2, and level 3. So if it is anterior disease and less than 1 centimeter, then it is A1. And when it is spreading on the sides as well as in the upper part of the vagina, then it is B compartment. And when it is approaching or present at the rectum or in and around rectum, then it is C compartment. And apart from these 3 compartments, there is F compartment, which takes care of uterine, tubal, urinary bladder, and other sites. So it is a classification which can be used preoperatively and can be confirmed during the operation. So advantages of using this classification is it provides really detailed description of the retroperitoneal structure, and that can guide the surgeon preoperatively and plan the treatment. So that is the beauty of this classification. The compartment can be divided into various sections, and patient can be counseled accordingly. The engine classification can be determined by imaging modality, which I already highlighted. The accuracy when compared with MRI and surgical scoring, it is quite good. accuracy, 95% with very low false negative rate. But they are the disadvantage also. It is not very well accepted classification at the international level. It is having very poor acceptance. It cannot be used for counseling because it is using a lot of anatomical variables and patient may not be able to understand. So that is the disadvantage. Then score can be inaccurate if the surgical dissection is not done completely. So until unless the surgery is also complete, you cannot use this classification for prognostication. And there are very few researches available to give it a weightage. Another classification which came into the recently in 2012, that is endometriosis fertility index. The purpose of the development of this system is to predict the pregnancy rate. None of the previous classification, they are able to predict the pregnancy rate. And in this, when we are using this endometriosis fertility index, we can actually predict the pregnancy on the basis of functional score. It is taking into account the historical and surgical scoring and then combining, giving the functional score of the tube. So it is basically useful for those patients who are not planning to go for IVF after surgery. So one can counsel using this endometriosis fertility index the patient, how much is the chance of conception if they go for conservative management. And these are the various parameters which are taken into account. There is the age on historical side, age, then previous pregnancies, then years of infertility, and they are scored by 0, 1, and 2. And second is the surgical scoring, and it is assessing the functionality of the fallopian tube, the fimbria, and ovary. So they are taken into consideration. And finally, the historical score as well as the surgical score is combined, and that comes the EFI score. And this chart shows the predictability of the pregnancy after getting the scoring. So how to interpret this EFI? The score is from 0 to 10 after completing the surgery. 5 points from each historical and surgical factors. And if I is more than 6, then the chances of higher pregnancy rate in that particular patient is there. So that is how it really predicts the pregnancy for those patients who are not planning to go for IVF. Limitations are there. We are not taking here the uterine factor, the gamete competency and stimulation, which can affect the chances of conception. Then lastly, there is the American Association of Gynecological Laparoscopic AGL classification, and it takes 0 to 10 point, dividing whole pathology into 4 levels. The level 1 is excision or desiccation of superficial implant. Level 2 is stripping of ovarian endometrioma. So it takes actually in account the difficulty during surgery, and that is how it is used. But again, the AGL classification is yet to be fully validated and published. It is already 10 years now, but it is still not very well validated. Lastly, there is another classification, which is endometriosis foundation classification. It is based on the location, very simplified, but again, it is not correlating very well with the pain and infertility and symptoms. There are 4 categories. One is the peritoneal endometriosis, then ovarian endometrioma, then deep infiltrating endometriosis, and finally,
Hello.
more
Sorry to
details.
interrupt you, sir,
I'm
but your time
finishing.
is up, sir.
Yeah, I am finishing in one, I think last slide.
Yes.
So deep infiltrative endometriosis type 2. The problem is it doesn't give insight. So many variations are there. Poor correlation is there. So this is the consensus, last consensus of Blood Endometriosis Society. They recommended that until better classification system have been developed, surgeons should use a toolbox for surgical classification of endometriosis that includes SRM classification, NGN classification, and EFI staging system to maximize the information available to the women. There are many reasons to have a new endometriosis classification which takes everything into consideration and might help the surgeon as well as the patient. So, dear friends, concluding my talk, it is the biggest challenge of the current classification system because there is not much correlation with the symptom. Currently existing classifications having limited research.
Hello. Yeah. Hello. Yeah. Thank you so much, sir, Kuldeep sir, for giving us a real crystal clear view on the various, stagings, the classifications, and how one scored over the other. And it's, I think, really, really challenging. Thank you so much, sir. I think
And
some
I request the speakers
connection
to
has
answer
been
the
lost.
questions. Sorry, I request the speakers to answer the questions in the chat box. Dr. Kuldeep too.
Yeah, we've got a lot of questions, madam. So I think that can go on side by side. And now I request Lakshmi Shirikande, madam, to please introduce, I'll just share the screen. Ramani, madam.
Dr. Pratik Tambe also has joined.
Okay, Lakshmi madam is there? So Dr. Pratik Tambe sir can introduce.
Good evening, everybody. Let me begin by thanking Dr. Ashara and ICOG for this opportunity to be part of the prestigious ICOG Endometriosis Certificate course. All of the certificate courses have been
Hello, Pratik sir. Hello. Hello.
Ritu, I think we are wasting time, Ritu.
Dr. Kundani Ramani does not need introduction. She has been the past, she has been the vice president, and she has also been an excellent chairperson of the endometriosis committee, and she compiled beautifully the guide GCPR in 2016 and wrote many more books later. And we welcome Dr. Ramani.
Yeah.
Thank you, madam. I will start sharing my screen. Yeah, hope you'll be able to see my screen.
It's still not visible, madam.
Not yet.
Okay. So part of my work has been made very simple by my previous speakers, that is regarding the pain pathway and management in endometriosis. I bring you greetings from Trichy, the city of Rock City. See, this picture is famous.
Madam, we cannot see your slides.
Okay, just 1 second.
I think you'll need to stop sharing and share again.
You need somebody. No, I'm not getting the stop share. Yeah, I will. Hope you will be able to see now.
Yes, madam. I think we'll be able to see. Yes, we are able to see, madam.
Yeah.
You can put it on the slideshow. Yes,
madam. Yeah. So thank you very much for giving me this opportunity. And the two important things in endometriosis is, one is we have to think about the pain, and the second one is infertility. So I bring you greetings from Tiruchirappalli, and this is a picture of Marilyn Monroe, who suffered from endometriosis, and it destroyed her marriages, her wish for children, her career, and ultimately her life. And she was suffering from pain, undergone so many surgeries, and finally she became drug dependent, and we do not know why she has died. So this all the information I can skip. And the prevalence is infertile patients, it is about 25 to 40%. 75% of the women with chronic pelvic pain, they have endometriosis, and 40 to 60% of the women with dysmenorrhea, they have endometriosis. Currently, WHO has announced it as a public problem. endometriosis is a public problem, and 256 million women all over the world suffer from endometriosis. Among 50 million women are in India alone. And this, everybody knows that the American society says that it should be viewed as a chronic inflammatory disease, and it should be managed lifelong, maximizing the use of medical management rather than surgical procedures. And the sites commonly, it can be either genital and extragenital, and there are so many years of surgical delay. The symptoms are, I usually say it as 7 days, that is dysmenorrhea, dyspareunia, dysuria, dysphagia, diffuse abdominal pain, dysfunctional uterine bleeding, depression, and finally fatigue. But the symptoms usually overlap in all these women. A particular patient can have both the acute dysmenorrhea plus dyspareunia, and it can be a diffuse abdominal pain at later stages. And you see 10% of the women, they do not have any, they are still asymptomatic. So why do you get pain? The pain pathway is mainly because it happens in the endometriotic implant, where there is increased aromatase activity, which will cause more and more of estrogen formation, as well as prostaglandin is produced in response to hyperestrogenism. There is deficiency of 17-beta-hydroxysteroid dehydrogenase enzyme system. Hence, the estradiol is not converted into estrone, so there is piling up of estradiol leading to increased prostaglandin formation, and it becomes both inflammatory and there is proliferative nature of the endometriotic tissue happens. There is reduced apoptosis, increased not only angiogenesis, but it is also neuroangiogenesis and altered immune responses. That all these things have been mentioned by the previous speakers. It can be, the pain can be central pathway, peripheral, as well as it is the nociceptive pathway that is very important. See, when these pain pathways are taken into the brain, see, even if you remove surgically the endometriotic lesions, the set pathway to the central, that is the nociceptive pathways, they remain persistent, and even a small trigger in the pelvic area can stimulate this. So this is about the central sensitization, and then about the increased production of pro-inflammatory substances like cytokines, chemokines, and growth factors and neuroangiogenic factors, and there is suppression of the anti-inflammatory substances. Then how to optimize the diagnosis is now very clear that there is no need for diagnostic laparoscopy nowadays. Just a simple symptoms, based on the symptoms you can treat it. That is been accepted by ESHRE, SRGC, and RCOG guidelines. Now coming to the medical treatment that has been described in detail by Dr. Pratik Tampe, I am not repeating it, but the non-steroidal anti-inflammatory thing is the simplest pain killer that can be used initially. It can reduce the endometriosis associated pain, and the advantage is that it will not inhibit the ovulation. Hence, patients who are having probable symptoms suggestive of endometriosis but no imaging evidence, they can use this drug so that it will not inhibit ovulation and fertility can be preserved. But of course, we know all the side effects of NSAIDs. Then comes other therapies are the combined oral hormonal pills, progestogens, GnRH antagonists, and agonist and antagonist. These are all available, and these are all it is available in the ESHRE guidelines. You can use combined oral hormonal contraception pill, but it can be either in the form of oral pill or vaginal ring or in the transdermal pathway. But it has got certain disadvantages. That is, according to Chaperon, when you use combined oral contraceptive pill in a young girl, it will mask the developing deep infiltrative lesions. And again, Professor Versilini says if you are going to use the oral contraceptive pills, it will act as a rescue factor. The regurgitated endometrial glands will otherwise, instead of undergoing necrosis, it will get proliferated. Then comes the progestins. Progestins, we have a lot of newer progestins, including the dynages, which are very helpful, and ESHRE guidelines and the World Endometriosis Society are very, and even the RCOG is very happy in using this dynages for pain management. So here, progestins can be either a medroxyprogestin, either it can be given oral or dipomedroxyprogestin. Dynages, we don't use ciproterone, but norethistone is a very good agent, which has got an equal efficacy to that of the dynages. And danazol, no more we use it orally, but it can be used in a different format. So dynages has been described by the previous speaker, so I am skipping it. And you have the Visada study, which says including adolescents, we can use it for a very longer time. There are studies which says that they have used it even beyond 9 or 10 years, and without it will not have much side effects and a minimal side effects, and the patient tolerability is very good. But we must understand, not all patients, they respond to dynages. 60% of the patients will respond to dynages, and the rest of them will not respond. And they are the patients who need some other form of treatment, like probably the GnRH analog. This is because of increased progesterone resistance, which is very prominent in 30 to 40% of the patient. So this is about the VISADA study that has been mentioned earlier. And then again, long-term use of dynages, as I said, Professor Thomas Romer, he has used single center study. He has used it for dynages even as a primary modality of treatment, or even after surgical management. When you continue to use dynages, it reduces the recurrence rate. So then the oral progestin norethindrone or norethistyrone acetate is a simple one which can correct the dysmenorrhea and the chronic pelvic pain, and breakthrough bleeding can happen, and the bone mineral density is maintained. That is one main advantage. With the disadvantages, HDL cholesterol is lowered, and this drug has been approved for pain management. Then comes the erythroprogesterone, that is the dydrogesterone, which is an excellent drug for pain management in women who are anxious to conceive. So probably following early lesions where it has been cauterized, we can put the patient on dydrogesterone from day 5 to day 25, 20 milligram in split doses or in a sustained release format. It can be given, which has got an immunomodulatory effect by suppressing interleukin 1, 6, and 8, and increases the nitric oxide production, and it has anti-inflammatory action. And more than that, it acts only at the utopic endometrium, not on the it acts on the ectopic endometrium and not on the utopic endometrium. Hence, it can promote fertility. Then comes LNG-IUS, which can be used primarily even in young girls, or it can be used following surgery, which has been already told. And there is an injectable progesterone, that is a Depo-Provera, can be given. It's a very simple, cost-effective drug, but only thing is we have to watch for the breakthrough bleeding and the reduction in BMD. So then comes the mode of action of the GnRH analog. Agonist, or they combine with the receptors, but there is an initial flare-up effect, then only they reduce the receptor, leading to chronic suppression. But whereas GnRH antagonists, they work upon the receptors directly, it suppresses receptors. So without the initial flare-up effect, it helps. So that is the main advantage. And this has been an accepted modality of treatment, GnRH analog, like either goserelin or leuprolide or decapeptide, anything can be used, or even a nasal thing is available. But only thing is, it can cause, if you are going to use for beyond a period of 6 months, you have to back up with some add-back therapy. Otherwise, it will lead to vaginal atrophy, dryness, and vasomotor pleasures, and it can alter the lipid profile. So the add-back therapy can be norethistyrone, a progestin that has been accepted. So in mild diseases, it can improve the pregnancy rates. That is, it can improve the outcome of pregnancy in IVF when you use it after embryo freezing. Then before transfer, you use this drug so that it will modulate the uterine NK cells, as well as it will suppress all the prostaglandins, and the endogenous hyperestrogenism can be curtailed, and it can promote the pregnancy. Then it can be used before surgery or after surgery when the patient is not keen on conception. If the patient is keen on conception, do not use any GnRH agonist therapy. So when it can be combined with the hormone replacement therapy, maybe it will reduce the bone mineral density reduction is avoided, and you can continue to use it even up to a period of 1 year very safely. But when you add back therapy along with calcium supplementation and vitamin D3 should be given. So the ESHRE guidelines 2022 says GnRH agonists can reduce endometriosis associated pain when other drugs are ineffective, and post-operatively we can use it. So there is a re-emerging role of danazol in the form of vaginal ring or in the intrauterine device, or sometimes simple danazol oral tablet can be used rectally or vaginally, which can be very effective using against the deep infiltrative lesion. Lower doses will not inhibit ovulation, and pregnancy can happen once if UPT becomes positive. Stopping this. But there are certain limitations of the current drug. NSAID can cause GI effects. Combined OCF pills can be nausea, vomiting, and all the breakthrough bleeding, and you have to have certain limitation. Only certain patients you can use it, and there are a lot of contraindications. And progestins, again, once again, it can cause increase in weight, breakthrough bleeding, depression, amenorrhea, and return of ovulation may be delayed. And GnRH agonist, mainly it has got central action and minimal peripheral action, and the hypoestrogenism is the main cause that why we are not using agonist. And danazol, it is actually very rarely nowadays used. So now we have to go about the newer strategies in medical management for reducing the pain. It can be the drugs which can reduce the estrogen sensitivity is antagonists, aromatase inhibitors, SERMs, and reduce the progesterone resistance is selective progesterone receptor modulator, reduces inflammation and pain is the monoclonal antibodies, prostaglandin receptor antagonist. These are all under the trial basis. And again, dopamine agonist, that is the gabapentin, is again an excellent drug which can reduce both angiogenesis plus neuroangiogenesis. Because in endometriosis, the presence of sensory nerve fibers are 14 times higher in the endometrium, and there is increased neural elements in the endometriotic tissue. So the available, now coming to the GnRH antagonist, available drug is elagolix, relagolix, and linzagolix. And this relagolix and combination therapy along with the ethinyl estradiol and norethindrone may be a better drug that can be used for pain management. And again, the efficacy of this antagonist that depends upon the dosage. For elagolix, it may be 150 to 200 milligram, or linzagolix, it may be 75 to 100 or even 200, and relagolix is 40 milligram with the add-back therapy. So when the patient has got a severe pain, probably we can start with a higher dose and then reduce it. So always a combination with an add-back therapy reduces the side effects as well as the reduction in the bone mineral density. This is what is when you are using a lower dose, the threshold level of estrogen is maintained, and an add-back therapy with a higher dose can suppress the pain to a quicker extent. So this is the effectiveness depending upon the dosage of the antagonist. So then reduction in BMD, I said it is higher the dose, more the reduction, add-back therapy reduces it. So then comes the second important drug, that is the second line drug, is the aromatase inhibitors in pain management. Patient not responding to any of this oral medications like the progesterones or the Dynegest or norethindrone, probably the aromatase inhibitors, either the anastrozole or the letrozole, may be a very good agent, because there is increased aromatase expression at the each endometriotic deposit, which can be suppressed. Not only the peripheral aromatase is suppressed, but also the local aromatase activity is being inhibited, and the combination of aromatase along with the progestins, like either we can use micronized progestin or norethindrone, can prevent the reduction in the BMD as well as the vasomotor changes. Then comes the nerve pain and the medication. As I said earlier, there is neuroangiogenesis, and there are also central pathways, sensory pathways, the peripheral pathways, and the nociceptive pathways, which can cause severe pain. So the patient suffers from pain during intercourse, pain during micturition, pain during bowel activity. So this can be reduced by suppressing the nerve stimulation that can be done by the antidepressant drug, that is the amitriptyline, but it has got its own side effects like dry mouth, drowsiness, arrhythmia, seizures, constipation, confusion, etc. Other drugs are chronic. They work by dampening down the activity of the nerves that are irritated or damaged in the pelvis. That is gabapentin, pregabalin, and it has again got its own side effect. This drug should be continued for a minimum period of 4 to 6 weeks. Then only the effect will happen. Then again, tricyclic antidepressants and anti-epileptics can be used, and it should be always a multidisciplinary action. Not only the drugs, but also the physiotherapy, psychological therapy are essential for pain management. So then narcotics will be the final one, and then comes the medical management. Beyond the medical management, if the patient is not responding, then we need to go for the surgical management. Early lesions can be cauterized or laserized or removed by using a butterfly-shaped excision. And ovarian endometriomas, it is always better to remove the oma. Cystectomy should be done instead of drainage and coagulation. And deep endometriosis is one thing. Primarily, you try doing it with the medical management, failing which you can go for surgical removal, but it should be done in a center of excellence, because we have a lot of complications.
Sorry to interrupt, ma'am, but
yes,
your time is up.
Yes, only one more minute. So the recurrence, for treatment of recurrence, you can use the GnRH analogs or LNG IUS, and the two more surgical procedures, either LUNA or presacral neurectomy, Among that, the presacral urectomy seems to be better than the neuro thing. And when you are going to do a hysterectomy for a patient in the perimenopausal period, better to remove along with the ovarian tissue, otherwise recurrence is going to be more. So then there are other complementary treatments like yoga, exercise, Chinese herbal medicine, etc. And lifestyle modification is the most important. And this is the algorithm. When with no asymptomatic it may be, or with the patient is symptomatic, start with the medical treatment in young girls, fertility preservation, and long-term completed the family medical management, failure of which we have to go for surgical management. To conclude, endometriosis associated pelvic pain warrants immediate attention to improve the quality of life. Start with medical management, and failure of which you can go for surgical management. GnRH antagonists are coming up in a big way, and you have to choose the individualize the patient to and select the treatment. So finally, I thank you once again for giving me this opportunity to say a few words about the pain management. Thank you.
So happy to see Dr. Kundan. Dr. Kundan, could you just conclude the session? Yeah.
Thank you, Dr. Ramani Devi, madam. I think it was a very lucid presentation on the pain management and the different agents. I think you have highlighted, especially about the newer drugs. I think they are coming up with a lot of evidence and, for the pain management, especially in endometriosis. So I think it was very excellent presentation. You have touched upon all the agents which can be used. And of course, like in contraception, we have to have a kind of a cafeteria approach for even medical management for pain control, because certain situations when it is to be long term, certain drugs are better, and when it comes to short term, certain drugs are better. So I think very nicely you have elaborated. Thank you so much for your presentation, and we can take over. We can go to the next presentation.
Yeah, I think we have Dr. Gaurav. Dr. Gaurav, you're there?
I'm here.
Yeah. So we'll you can just introduce Dr. Damodar. I'm just sharing the slide. Thank you, Dr. Kundan. Thank you, Ramani madam. Over to you, Gaurav, to introduce Dr. Damodar.
Yeah, good evening, everyone. First, I'd like to thank the ICOG and the organizers for inviting me. I'd like to introduce a certain Dr. Damodar Rao. Apart from being a good friend and a talented endoscopic surgeon, he has achieved several feats and accolades in his career. He is, of course, associated with the Coimbatore chapter of ISAR, of IAG, and many other organizations, including FOXY. He is also the Shah S. Ratnam Young Gynecologist Award at AOFOG, and he has a number of various contributions in the field of endoscopy and infertility. So, Damodar, over to you.
Yeah, thank you, Gaurav, for that kind introduction. I think my topic for today is going to be about endometriomas, and I'm going to share my screen and pray that it opens. Can you see it?
Yeah. Yeah.
All right. Yeah. So we're short of time. I'm going to just talk about, stick to slides that are really, really important for this particular topic. So my topic is about surgery for endometrioma, when and how. I think all my previous speakers have spoken a lot about, medical management, about etiopathogenesis, and a bit about surgery too. So I'm going to skip a few slides and directly talk about endometriomas, the indications, right, for surgery. I'm going to be sticking more towards fertility. So let me just talk about why are we really, really worried about surgery for endometriomas. It's not like any other ovarian cyst, right? Most of these patients come to you with fertility and we're worried about ovarian reserve. Compared to dermoid or cystic adenomas, the amount of ovarian tissue that's lost during endometrioma surgery is high. The planes are not great. So you got to be very, very careful in your patient selection. There is enough evidence to suggest that there is a fall in AMH, especially if you're operating on a bilateral endometrioma. They're even talking up to a fall in AMH by about 67%. So you got to be really, really careful when you embark on the surgeries, and patient selection is very, very important. So if you have a young patient, regular menstrual cycles, an incidental finding of ovarian endometriomas, then probably you could try and just, give her the chance of a spontaneous pregnancy, because they do say that 43% there is a chance of spontaneous pregnancy rate during the 6-month follow-up period, right? So that's something you should give that benefit to the patient. Indications for surgery really, one is pain, which is not controlled by medication. Just because she has pain, you shouldn't go in for a surgery. You should look at, give her medical management, right? We've spoken about various medicines that can be given. Failure of medical management is definitely an indication for surgery. Size is not a criteria anymore. Like before, they used to talk about 3 centimeters and things like that. It's not a criteria anymore. If she's for endometriosis, if she's a good, it's basically a tailored protocol. You can't really give a blanket rule, so to say. So if the patient has good AMH, is a young patient, unilateral endometriomas, tubes are all right, then probably you can, but all these patients always, right? Only if failure of ovulation induction and things like that have failed, then probably you can think of surgery. Again, bilateral endometriomas, if she is young, and her AMH is good and other methods have failed, then probably you can, other methods in the terms of not IVF, but if I'm talking about like ovulation induction or IUI, if all those have failed, then you can think of operating on these patients, because this surgery is not the only surgery for her. She's probably going, you could be the best surgeon in the world, but she's definitely most probably going to land up with another surgery. And let's hope the time interval between this surgery and that surgery is quite long, right? Another indication for surgery is size is too big, then it might come in the way of your oocyte retrieval. That's another indication for surgery. What are the techniques available to us? We have cystectomy. A lot of vasopressin is used nowadays. I use vasopressin a lot. Then you do your incision and ablation alone and just let all the cyst fluid out. And the 3-step technique that was popularized by Donny back in the day, which is not done now much anymore. Cystectomy, I'll get into the video directly. It's always done best with an assistant holding the ovary up, and you try and walk on the surface of the cyst and the cortex. Don't hold the edges and just try and pull it apart. Go meticulously, like I use the word walk on the surface of the ovary, and you'll be able to get into a decent plane. There's never a right plane, right? Like the ovary is like an onion, they say, right? You can get various layers to it. So see what is the best layer. You should leave enough amount of pink on the ovarian, on the ovary. If a lot of pink color tissue is going along with the cyst wall, maybe you're in the wrong plane, but then you got to rethink your strategy and see what you can do. This is a video which shows you complete removal of the cyst. But nowadays, they say that when you reach the hilum of the ovary, the blood supply is maximum at that particular point. And we got to be careful when we reach the hilum of the ovary. Now, it's advocated that you can use some sort of ultrasonic energy and maybe even leave behind a little bit of cyst wall when you reach the hilum of the ovary. Because if you yank it like this, when you reach the hilum of the ovary, there's a tendency for it to bleed. And the hilum is the most vascular part. And then you might go and apply a little bit of, bipolar energy or some sort of cautery over there. And there is a chance of further loss of ovarian tissue. So like I was saying, the hilar region is called the Achilles heel of the ovarian cyst, and great caution should be taken to avoid damage while stripping the cyst wall and hemostasis near the hilum. So you got to be very, very careful. This is the same thing, retaining the hilar region. So vasopressin has been injected. A lot of people inject vasopressin into the cyst. Some people inject vasopressin into the ovary or into the infundibulopelvic ligament. I have a habit of injecting vasopressin into what would be into the ovarian cyst, basically. The layer, what you think is the layer between the cyst wall and the ovary. First, you drain it out completely. And here you can see that vasopressin is being injected. And you tend to get a decent plane. And the advantage is the amount of oozing is very, very less when you use vasopressin. So it's basically diluted vasopressin, just like what you use in your myomectomies, right? It's the same principle that is used. So this is another video where I'll show you vasopressin being used. So always the principle is mobilize the ovary of the ovarian bed completely. That way, you're sure that the ovary is completely mobile. Once you know that it's completely mobile, then you go ahead and proceed with cystectomy. If you've not mobilized the ovary completely, sometimes the cystectomy may not be complete. You may not be, technically it becomes difficult to complete the cystectomy. So always see that you mobilize it completely. Here again, you can see that vasopressin is being injected. And you can see that I've gotten to a decent plane over there. And the vasopressin itself seems to be doing the cystectomy, right? If you get into the right plane many times, the so-called right plane, you can see that the cyst wall is bulging out. And all you have to do is, kind of give a shearing motion over there, and you'll see that the cyst wall is exposed. So once you can see this is, all this fluid that you can see is just the vasopressin. It's not really blood. And then you can go ahead and do a cystectomy. You can always see I have an assistant holding the cyst wall, and you can go ahead and operate in this part. So you can see that nice clean cystectomy is happening over here. And as I reach the hilar region, I'm using some amount of harmonic, and I'm leaving behind a little bit of cyst wall so that the hilum is not really affected, right? There is also another technique where if you're not able to get a good plane, usually we start doing our cystectomies from the periphery of the cyst, right? But the periphery of the cyst is the most adherent part of the cyst. The least adherent part of the cyst wall to the ovary is the center of the ovarian cyst, right? So after you've drained it, you're always, again, trying to, mobilize it nicely. And once that's done, okay, you evert the cyst wall. And then here I'm injecting vasopressin also. And then you start doing your cystectomy from the center of the cyst, right? So you divide the cyst, so to say, in two halves. And you can see that. And then you start peeling off one half, right? And then you do the other half. So I'm going from the center to the lateral of this lateral part of the cyst, to the periphery of the cyst. And you'll get a good plane in such areas, right? And while doing the cystectomy, like I said, always see that there's not too much of pink coming out on the cyst wall, then probably you're in the wrong plane. So these are small principles that you should stick to. And if there is some amount of bleeding, you can just do pinpoint coagulation. Don't go and coagulate the whole base of the ovary, right? So that's one more method where, you can get into a nice plane. So what's the effect of vasopressin? There's been a lot of studies that have been done, and they found out that vasopressin injection is an ideal procedure to reduce damage from usual laparoscopic cystectomy of endometriomas, and they protect the ovarian reserve. What about vasopressin? And sometimes if you inject vasopressin, there still can be bleeding, and in such cases, what I do is just go ahead, instead of applying a lot of thermal energy, you can go ahead and just suture the ovary in this technique. That way, there is less damage to the AMH, right? So are the advantages of suturing over bipolar? So that they definitely say that suturing has an advantage in terms of thermal energy is, you avoid thermal energy to the ovary, and it really helps. Hemostatic sealants, given the cost of the sealants, and there is a chance of, small bowel obstruction sometimes because of these sealants, they're not very, very popular. Three-step technique was done back in the day. It was popularized by Donne. Basically, you incise and drain the chocolate fluid. Then you give her GnRH for 3 months, and then you again take her up for, the cyst wall ablation with laser. This is, no patient is, going to come onto the table within the span of 3 months, right? Twice. So it's not very popular. Something what Horace Roman has been trying is cystectomy with I'll just show you the video with plasma energy that also seems to be helping. So what did Eshrey say? Ovarian endometriomas, excision of the endometrioma capsule instead of drainage and electrocoagulation is the best to increase the spontaneous pregnancy rates. Only in people who have had previous surgeries, right? Previous surgeries on the ovarian tissue, you really have to think many times before you're going to operate on such patients. Probably IVF is a better option. And regarding size, like I spoke about it, there is no real cutoff for size. Only thing is, if you want to operate on endometriomas, it's for pain or for your oocyte retrieval, you're not able to access it properly. What about hormones after surgery? Not really recommended. The best time to become pregnant is soon after surgery. Newer interventions, like I said, this is not my video. It's a video of Horace Roman. Basically, he uses plasma energy. He everts the cyst wall, like I showed you, everting the cyst wall. And it's cheaper. This technology of plasma energy is cheaper than laser. And you basically kind of coagulate the cyst wall. And he says the recurrent rates and the pregnancy rates are as comparable as cystectomy, right? So damage to the ovarian reserve is less. So basically the whole cyst wall is coagulated, and there you can see it just looks charred, but it's not as bad as it looks. Okay. Ethanol sclerotherapy is again making a comeback. It was tried back in the day, and now it's again. Back in the day, it was done via transvaginal route. Nowadays, through laparoscopy itself, ethanol sclerotherapy is being done. Basically, it's done if it is a nice unilocular cyst. You make an incision and then you use 95% ethanol. You use a Foley's. You basically suck out all the chocolate cyst fluid. Yeah, that's it. And then this is the cyst being cleared out completely. And then you insert a Foley's and you inflate the bulb. And then you push in ethanol, and then you wait for about 10 minutes while damage to the cyst wall occurs, right? And at the end of the procedure, you can take out all the ethanol. So this is also done by Professor Horace Roman. And when I went to France for training in endometriosis, he was already doing this. So again, he says that the rates, the recurrence rates and pregnancy rates are very good. And the damage to the AFC is a lot less. Sorry. So yeah, that's the end of my talk when it comes to endometriomas. So yeah, deter from surgery as much as possible. But if you have to operate on her, let her first surgery be her only surgery. Try medical management as much as possible. And only in certain cases, like I've spoken about, go ahead and do the surgery. Right? Thank you. Thank you so much.
Dr. Gaurav? Please unmute yourself, Dr. Gaurav.
Yeah, thanks, Damodar, for that talk. Any take on robotics versus laparoscopy? What is for endometrioma?
No. I don't think there's any big advantage that you have. Robotics is not going to give you. I think if you have a good 3D system, which gives you good amount of depth and good clarity, if you're a good laparoscopic surgeon, I don't think robotic has any advantage in an endometrioma.
Yeah, thanks for the talk.
Thank you so much, Dr. Damodar and Dr. Gaurav. I'll do this share screen and request Dr. Pratik Tambe to introduce the next speaker. That's Professor Sylvia.
I think earlier we had a little internet issue, so apologies for that. I'd like to express my gratitude to Dr. Ritu Khanna, Dr. Asha Rao, and ICOG for this opportunity. We are very privileged to have a distinguished international speaker in this ICOG endometriosis course. This is Dr. Professor Sylvia Vanuccini. She is an associate professor in OB/GYN at the University of Florence. If you are not aware, Florence is actually the city where you'll be able to see David and all those beautiful sculptures. But we are going to be talking about endometriosis. So her scientific interest is devoted to uterine disorders, obviously endometriosis and fibroids. And during her PhD program, she focused on these issues. She regularly attends multiple meetings abroad, and she is a very sought after speaker and co-author of more than 100 peer-reviewed papers. Over to Professor Sylvia Vanucini, and she's going to be speaking to us on GnRH antagonists and their role in gynecology, specifically endometriosis.
Yeah. So over to tech team to share. So good afternoon to everybody, and it's a great pleasure for me to be here, even though it's a remote connection, but I'm very happy for this invitation. So I really thank you, all the team. So my task today is to talk about the GnRH antagonists in gynecology. We will focus more in endometriosis, but we will provide an overview on GnRH antagonists and their emerging role. So we know that very commonly we have a combination of benign uterine disorders. So it's not that uncommon that we can find endometriosis together with other disease, such as adenomyosis or even uterine fibroids. So in many situations, we have a complex patient or many complex patients. So, and we even know that there are some differences, but also similarities between endometriosis, adenomyosis, and uterine fibroids. We know that all these conditions are hormonal related. There is an increased estrogen receptor estrogen receptivity, dysregulation of progesterone receptor, and there are some similarities. So most of the time we may use even the similar treatment. In fact, especially if we think about hormonal treatment, we know that there is a list of treatment available, like of course for symptoms related to heavy menstrual bleeding or pelvic pain. We know that in our hands we have combined oral contraceptive, progestin-only pill, progestins, even general. For the future is already available, not in all the countries. In Europe, we have available some of these drugs, not all of them. But we may go into depth in this chapter. We are already aware of the importance of the GnRH
Some internet issues, I think. Let's just wait for her to reconnect. Gauri and backend team.
Hello. Hello. Gauri. Hello. Gauri. Suddenly shut down with the video. Hello.
I think there's some internet issue. We'll just wait for that.
Yeah, I think it's
Probably sorting it out in the
on
back.
their side, I think, on the tech team side with the
Yeah,
internet.
In the meantime, I think we've all had very excellent talks in all the preceding sessions. All the speakers kept to time and they addressed the topics in a very precise fashion, which is nice. And I think all of our audience must have learned a lot of important key practice points. They're all waiting for the post test. I'm seeing in the chat box, but we have one final talk to go. We'll complete that and then we'll conduct the post test. Please bear with us in the meantime.
I think we can't see any of the tech team here. Maybe.
I'll just try and call Nilima.
Yeah. Asha ma'am, are you there?
If any of the speakers are around, we can ask them questions.
Yeah, मैं फिर से share कर रही हूँ.
Yeah.
hand, we have an elevated efficacy, but on the other hand, we have a shorter use, not up to, so up to 6 months normally, hot flashes, so all the menopausal symptoms, and also elevated cost. So what about the GnRH antagonist, which is the new class of drugs available? I'm showing here these three names, which are elagolix, rilugolix, and linzagolix. They competitively bind to GnRH receptors in a dose-dependent manner. And they are, which is the main difference. There is an oral bioavailability. So we remember that the GnRH agonists are injection, whereas in this case, this is oral. They have a direct antagonist effect, so they cause an immediate GnRH suppression. So there is no flare-up effect, which may impair a little bit the compliance of patients in the first month. Then there is a dose-dependent suppression. So even a partial suppression is allowed, depending on the dosage we use for each compound. They have a fast action, so they are also rapidly reversible. They may be stopped at any time. And even in the long term, which was the side effect or the consisting in GnRH agonists, in this case, if we use an ADVEC therapy, we may not have any significant effect on bone mass density. So what is important is really the new adventure is the combination therapy, because we know that in case we use the agonist, we get a full suppression of the estradiol levels. If we use the monotherapy of the oral GnRH antagonist, we may have the similar suppression of the GnRH agonist if we use a high dosage, whereas if you use a low dose, we may have a partial suppression. In case we combine an ADVEC therapy, we may leave stable the estradiol concentration in the therapeutic range. So for all the uterine disorders, and especially for endometriosis, our aim is to optimize the reproductive hormone ranges. So to achieve, on one hand, the symptom control, and at the same time, we want to maintain healthy bone metabolism to prevent all the menopausal symptoms. So in terms of, I will start with the fibroids, because as I've mentioned earlier, we are using these antagonists not only for endometriosis, but also for uterine fibroids. Actually, we see here the three compounds. The first one is elagolix, and the trial was published in 2020. And then in 2021, another compound, which is a rilugolix combination therapy, was published in the Liberty 1 and 2 trials. And then in 2022, the Primrose trials were published on linzagolix with and without ADVEC therapy. And we will explain better the differences. So in this case, you see the elagolix. So elagolix for heavy menstrual bleeding. The aim is to control the heavy menstrual bleeding. And you see here, we have three different arms. One arm with 300 milligrams twice a day, combined with ADVEC therapy, which is 1 milligram estradiol and NITA, so norethistérone acetate, which is in another pill. So you should consider that the patient needs to take 2 pills of elagolix and 1 pill or 2 for the ADVEC therapy. This was compared to an arm with elagolix alone, 300 per twice a day, and the placebo. And if you look at the endpoint, which was the reduction of bleeding for each cycle, you see that elagolix, even though it was combined with ADVEC therapy, was effective in reducing heavy menstrual bleeding in women with uterine fibroids. And what is really important is that if you look at the population of having uterine fibroids combined with adenomyosis, this treatment was available and was efficient also in this subgroup where there was a coexisting condition and it was effective in reducing heavy menstrual bleeding. Unfortunately, I cannot share my experience on elagolix because it is available only in the US, so it's not approved and it's not available in Europe, so we have no experience on that. Whereas we have experience on relugolix combination therapy. So this is just one pill. In the same pill, you have 40 milligrams of the GnRH antagonist, which is relugolix, combined with estradiol and 0.5 milligram of testosterone acetate. So this is the two or three trials, the Liberty trials on the administration. Again, you see there are three arms, one placebo arm, one arm with relugolix combination therapy, and they also try to administer just relugolix, so alone, without that therapy for 12 weeks, followed by relugolix combination therapy, in order to see if there were any advantage of taking the GnRH antagonist alone. And again, the primary endpoint was the proportion of responders decreasing their menstrual blood loss significantly. And here you see that the menstrual blood loss was reduced by 90% at week 52, so after 1 year, but the menstrual blood loss drops by over 50% by week 4. So the short action you may see here in this graph. And there was also a significant reduction in uterine volume, not a huge reduction, but you may see that at least a 15 reduction in uterine volume was observed. And what about the side effects? Because we know that if you take the antagonist alone, you may have the same effects of the GnRH agonist. Whereas here, with the combination therapy, you see that the bone mineral density was preserved in the lumbar spine of women treated with relugolix combination therapy. You see the orange line where the decrease in bone mineral density was really not significant. It was pretty much the same at baseline. What about linzagolix? Linzagolix, in that case, the trial where, again, you may see that here the antagonist, the linzagolix, is alone. So in case you want to prescribe the ADVEC therapy, you need to prescribe as another treatment. And you may have a linzagolix, a different dosage. You may have the 100 dosage, 200 dosage is 1 pill per day, once a day, or you may have a linzagolix plus ADVEC therapy, 100 or 200. These were compared to the placebo. Again, the ADVEC therapy was exactly the same, so estradiol and nortestosterone acetate. And here again, you may see a significant reduction of heavy menstrual bleeding after 6 months and then after 1 month. So it was really effective. And again, something very interesting for people dealing with endometriosis patients, that linzagolix was tested also. It was just a few, so a case series. It was not a trial, but it was tried also in adenomyosis. And you may see that there was a significant reduction in the uterine volume. So it may be even an option for adenomyosis. Again, I cannot tell my experience for linzagolix because, again, the approval of the linzagolix is still in progress. So so far we have available relugolix combination therapy. And here you may see a summary where GnRH antagonists plus ADVEC therapy were effective in reducing heavy menstrual bleeding. You see that the results were pretty much the same if you compare the data adding the ADVEC therapy, and their bone mineral density was actually preserved. So in the end, there was a reduction in heavy menstrual bleeding, improvement in symptoms and quality of life, reduction of fibroid and uterine volume, but this was especially without ADVEC therapy. So in case our aim is to reduce the uterus, we should think of a compound without ADVEC therapy, for example, the linzagolics, even for high dosage. But we should bear in mind that if you use the high dosage, it shouldn't be for long term, but just for short term. Otherwise, you will have a bone mineral density loss. Okay, so let's move to the chapter of GnRH antagonist for endometriosis. So we have mentioned all the compound for uterine fibroids. And then for the endometriosis, which are exactly the same, elagolix, rilugolix, and linzagolix. Elagolix was the first approved in the world and is available in only in the US, so I cannot share my experience on that. Then rilugolix was approved in 2022 with the Spirit 1 and 2 trials. And very recently, the two here, so the long-term data were published on the rilugolix combination therapy for endometriosis, whereas just appeared the publication on linzagolix with and without ADVEC therapy for endometriosis. So what about elagolix? You may see here that the dosage is totally different. For the uterine fibroids, we had 300 milligrams. In this case, for endometriosis, there are two dosage. One is 150 milligrams once a day, or 2 milligrams twice a day. So the low and the high dosage. The trial was for 6 months. And only women with surgically diagnosed endometriosis and moderate or severe endometriosis-associated pain. So I want to stress the importance that these compounds are mainly for those who are resistant to first-line approach. So for those with moderate to severe endometriosis-associated pain. And in that case, you may see that both higher and lower doses of elagolix were effective in improving dysmenorrhea and non-menstrual pelvic pain. But of course, those who received the high dosage had significantly better results with respect to the use of painkillers. But more than 50% of women in each trial reported at least one adverse event related to menopausal symptoms such as hot flashes, headache, nausea, and there was also a significant reduction in bone mineral density. So we cannot think of this treatment without an ADVEC therapy if you continue the treatment after 6 months. What about the rilugolix combination therapy? We have mentioned it before. So it's again with just one single pill with inside the rilugolix, which is the GnRH antagonist, and the ADVEC therapy, just one pill. And here in the Spirit 1 and 2 and the extension study, again, there were 3 arms, one placebo, one rilugolix combination therapy, and the third arm with rilugolix combination therapy alone for 12 weeks, and then followed by the combination therapy, just to see if there was any advantage to have just the monotherapy. And what about the result? So there was more than 50% dropped in the actual amount of analgesic used from baseline after 6 months. And this was, again, well, in the combination therapy. Then if you look at the dysmenorrhea, it rapidly decreased from severe to mild by week 8. So it was quite a short-term effect, and it was sustained through 2 years treatment. So it was really an efficient treatment and a significant improvement of endometriosis-associated pain. There was also a decrease in the overall pelvic pain from moderate at baseline to mild at month after 6 months, and sustained through well, 2 years. And also the dyspareunia decreased from baseline after 6 months and sustained after the end of the trial. So there were really very good results. Even the daily functioning, so all the quality of life questionnaire that were used demonstrated an improvement in quality of life. And there was also a low incidence of adverse effect, a mean decrease of less than 1% in bone mineral density that did not progress during long-term treatment. So our aim is to optimize, again, hormonal ranges on one hand to improve symptoms and on the other hand to maintain bone health. We know that endometriosis lesions do not grow at lower estradiol level, so like those in the early follicular phase. So we should maintain these range, these levels into this range. And if you compare, so just look at the linzagolics because the data has just came out in the literature, you see that even with linzagolics, by using the 3 different dosage, the dysmenorrhea percentage was decreased significantly after 6 months, not only dysmenorrhea, but also non-menstrual pelvic pain. But what was the side effect was that linzagolics, yes, it significantly reduced the endometriosis-associated pain and improved quality of life at the doses 75 to
Some audio issues again, I think, some internet problems.
Yeah, I think it's almost over. So, Dr. Pratik,
Yes,
we
yes,
request
it's
you to
almost over.
All right,
Dr. Pratik
so
can perhaps conclude the talk.
yeah, okay. So I'd like to express my
की पैसा
gratitude
है
to Professor Sylvia for that wonderful talk. I think that was an eye-opener talk for many of us because it spoke about a class of molecules which is not yet available in our country. And these are the emerging frontiers, GnRH antagonists, which are in oral format. Those of us who practice IVF, of course, are aware that such molecules exist, but for general OBGYNs who may be there as part of the audience, they wouldn't be aware. And elagolix and that particular class of molecules, we hope are going to be introduced in India very shortly in just 2 or 3 months. They will represent a unique challenge for us because many of us are not familiar with this class of molecules. We are going to be utilizing them in clinical practice. And as she said in her talk, they are again not licensed for use in Europe. So whatever little experience we have is from case studies, from case series. There are not too many RCTs, and the few RCTs that we have, they show that there is a significant amount of hot flashes and other side effects. There is some extent of BMD loss as well after 6 months, and therefore they need to be combined with add-back therapy. And the add-back therapy which they've recommended is norethistone, which seems to work quite well. And hopefully we will have more experience with this in the months and years to come. Thank you again, Dr. Ashara and Dr. Ritu Khanna, for inviting me. It was a wonderful talk and an excellent course. Thank you, everybody who's participated in it so far.
Thank you so much, Dr. Pratik Tambe, for summarizing the talk beautifully, and thank you for your precious time.
Yeah. So, Gauri, can we have the link shared for the post test?
Yes, ma'am.
Yeah, please share the link and then we can have over to Asha Madam for the post test also.
Yeah. Nilima will display. I think all are very busy doing the answers. ಹಲೋ எனக்கு இன்னும் 10 நிமிஷம் ஆகும் நேற்றுக்கு வாங்கலையா இன்னைக்கு எவ்வளோ இருக்கு Time up. How many have submitted?
Yeah, I think it is done, ma'am. So we'll have the screen share for the answers to the questions. Yes, Asha ma'am, over to you.
Yeah. Okay. Yeah, we had a very nice day, and I'm sure the questions are pretty good. Percentage of adolescents with chronic pelvic pain diagnosed with endometriosis is 25 to 28%. Of course, there can be a little dispute. Sometimes it can be even as high as 50 to 60%. Published data suggests time between symptoms and clinical diagnosis of endometriosis is 9 years. Right answer. Which is not the risk factor for endometriosis, polycystic ovarian disease. Question number 4. Answer is burnt matchet type lesion and E-tubal block. These are not seen on laparoscopy. Which are the following that may not be used for prevention of post-op recurrence of endometriosis? Answer is estradiol. Definitely estradiol is not used for prevention of post-op recurrence of endometriosis. Yeah, can you scroll it further? Which of the following factor is decrease in endometriosis? Th2 cytokines. Next. The first line treatment for pain relief in endometriosis is NSAIDs. The fourth generation of progestogen, which one? Dynagest. And question number 9, the answer is induction of hypoestrogenic state, reducing endometrial implants. There's the action of GnRH agonist. What is the main goal of endometriosis management? Relief of symptoms and improvement of quality of life. Question 11. What is deep infiltrative endometriosis by definition? Peritoneal penetration more than 5 millimeter. There is one more definition which also says that penetration into neighboring structures like bladder, bowel, etc. But this is one of the common definitions. Important soft marker for ultrasound diagnosis of DIE is sliding organ sign. Bowel endometriosis does not show this sign, that is hypoechoic hat sign. And question number 4, following statement is true in relation to classification of endometriosis. All of the above. And question 15, this is not a sign of endometrioma, acoustic shadowing. 16, answer is all of the above. Preoperative preparation for bowel surgery. Okay. 17, what is the cutoff size of ovarian endometrioma for surgery? Earlier, H-ray had a size of 3 centimeter. Today, if you look at the H-ray guidelines, the size is removed. It is only depending on the circumstances, so size is not a deciding factor. And if the patient's AMH is normal, the best technique would be cystectomy. Ethanol sclerotherapy, 95% alcohol is used. Ethanol is used. Following are true for endometriosis fertility index, except A, used to predict the pregnancy rate in patients after surgery for planning to become pregnant with IVF. No, it is for natural conception, not for IVF. 21, medical management of endometriosis is most effective for pelvic pain. 22, the following is true about Dynagest, except it has androgenic side effect. It does not have androgenic side effect. Yeah. 23, GnRH agonist depot is effective in endometriosis by the following effect, that is pseudomenopause. Following agents can be used for add-back therapy for prolonged GnRH agonist depot, and that is tamoxifen. You can use estradiol, but tamoxifen also can be used, and not other compounds like letrozole or GnRH antagonist. 25, the following agent is no longer preferred due to the androgenic side effects in the medical treatment of endometriosis. Danazol. Danazol used to be our favorite drug of yesteryears, but today it is abandoned. What is the incidence of endometriosis? Is 10% in the reproductive age group. What is the oldest theory of endometriosis? Of course, Samson theory. And what is the latest theory? That is microbiome theory. Which enzymes aid in the development of endometriotic invasion? Matrix metalloproteinases. Last question. What is the main hormone involved in the pathogenesis of endometriosis? Estradiol. So I'm sure we had some technical hitches, like some presentation did not open. But for that, I think it was a very nice day. And it is time for me to thank everyone because it was such a wonderful day. Let me thank the ICOG team, Dr. Parul Kodidawala, Sarita Bhalerao from Foxy, Dr. Jaideep Tank, Madhuri Patel. Then we have Dr. Parag and Sheila for their excellent guidance, support, encouragement, and giving us the chance to do this course. And I thank the speakers, Kalpana, Kuldeep Jain, Parikshit Tank, Ramani Devi, Sonal Kotadawala, Sonal Panchal, Damodar, and Sylvia. The lectures were excellent and crisp, though maybe next time we can allot a little more time. And I also thank all our chairpersons, starting from the senior most Dr. Mandakini Meg. So all the chairpersons did excellent job, excellent moderation. And last but not the least, Ritu Khanna, always bright and beautiful, efficient, perfect. She's Miss Perfect. Thank you so much, Ratu. It was such a pleasure. And I did not have to worry about anything. And the ICOG team, ever smiling Nilima, she's totally flawless and never sniggers, never says it's late. So thank you, Nilima, Gauri, and the team for the wonderful support that we enjoyed from you. So tomorrow we are starting again at 4 o'clock. And I'm sure tomorrow is going to be a better day than today. And all of you are going to enjoy this session. Anything from you, Ritu?
We learned a lot. There were fantastic deliberations, all the chairpersons, and we had almost everybody into it. We weren't to miss anybody. And we had also with us Subhash and Anu also. So it was a great time. And thank you so much to ICOG team, Dr. Parul and Dr. Sarita Madam, and our series convener, Dr. Parag, Dr. Sheila, and Dr. Chamila. We missed her, though she was busy somewhere. But always, of course, our wishes and everything is with her. Thank you so much, Asha Madam, for giving this opportunity.
Yeah. Madam, on behalf of everybody, all the
Subhash, I keep thinking Subhash is in US. But Subhash is
yes.
Thank you so much, Subhash.
No, ma'am, on behalf of all of us, ma'am, would like to thank you, Asha ma'am, for taking this initiative at the first place.
Yeah.
And secondly, ma'am, and I think put in a lot of efforts. I think Dr. Ritu madam also did suggest, whole of day one was taken a lot of efforts by.
I did not have to worry about anything.
No, a lot of efforts by Ritu madam.
I was made to bring Subhash back to India, Asha madam told me.
It's like like Pratyaksha, the god.
Thank you, Asha ma'am. I think genuinely you put in a lot of efforts. Thanks to you, Ritu madam. Again, Gaurav, thanks a lot for all the efforts that you put in. Thanks a lot for all the work done, ma'am. Thank you very much, ma'am. And looking forward to everybody to meet at 4 p.m. And I think there is one Dr. Harpreet who has suggested that we should we should increase some amount of time to the speakers so that the speakers would have more time to speak.
Definitely, yes.
Point taken, Harpreet ji, and we'll see to that. We will do some changes tomorrow for tomorrow, right? Asha Jain ma'am, nice to meet you. Vidya ma'am, nice to meet you. And thank you everyone on behalf of team. Thanks a lot.
Thank you, madam.
Thank you.
Always good to see
Thank
you.
you, Gaurav.
Thank you.
madam.
Thank you for refreshing our knowledge.
Hi, Dr. Meenu, Dr.
Lovely seeing you, Asha.
Dr. Ambuja, ma'am.
Namaste.
Hello, ma'am.
Oh, BSOG, Nagaratna madam, namaste. Meenu Vesh ma'am, looking forward to your meeting next month. Next month at Dehradun, ma'am.
So you're going to be there.
Hi, Vidya Tobi.
Yeah.
So lovely seeing all of you.
Yes.
And have a nice evening.
Thank
See
you.
you all.
And goodbye.
Good
night to everyone.
Nice to see a lot of people from Kerala and Calicut, ma'am. Lot of them from Ramakrishna is there. Lot of people from Kerala also. Nice to meet everyone.
Looks like she's sitting in Calicut. Is Asha Jain sitting in Calicut?
Nahi, ma'am.
No.
Nice coconut trees and see behind her. I thought you
Asha
hosted
madam,
especially in
Asha madam
Calicut.
carries those coconut trees with her, you know, wherever she goes, she's so fond of them.
Makes me feel good, having it behind me.
Yeah. Right. Okay then. Goodbye and good night to
Bye-bye.
everyone.
Good night,
Thank
good
you.
night. See you
Thank you.
all.
Bye.
Asha, I want to
Bye.
take a picture.
Yeah.
Yeah.
Thank you.
Asha and Ritu have taken a picture. Okay. Thank
Yes.
you.
Thank you.
Okay.
Good night.
Bye-bye. Bye. Bye.
Yeah.
Bye-bye.
See you all tomorrow.